Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin.
Story 1. Scalpel Count. I found it on my locker shelf the next morning. The scalpel with the rusted handle, sterilized and gleaming, placed precisely where my coffee mug should have been. I've been an OR nurse for 11 years. In that time, I've learned that surgical precision extends far beyond the incision site. It lives in our protocols, our counts, our obsessive verification of every instrument that enters and exits the sterile field. The final count isn't just procedure, it's liturgy. We repeat it twice, sometimes 3 times, checking each blade and clamp against the initial inventory sheet. Nothing leaves the theater until every item is accounted for. Nothing. It was a Tuesday evening, late autumn, when our routine faltered. We'd just finished a routine appendectomy in OR4, a straightforward case with minimal complications. Dr. Brennan had already left to update the family. The anesthesiologist was documenting vitals. I stood at the instrument tray with Kelly, our circulating nurse, conducting the final count. "Scalpels," I called out, touching each blade with the tip of my pen. 1, 2, 3. I stopped. There were 4. Kelly glanced up from her clipboard, her reading glasses perched low on her nose. 3 scalpels for this procedure. Check the sheet. I checked. She was right. We'd opened 3 sterile packs at the start. I'd handed Dr. Brennan 3 blades throughout the operation. But now, arranged neatly on the stainless steel tray, there were 4. The 4th scalpel sat slightly apart from the others. Its handle was different, older with a faint rust discoloration around the grip threading. A small inventory tag dangled from the shaft. The kind we stopped using in the early 2000s when the hospital switched to barcode tracking. I picked it up carefully, turning it under the surgical light. The tag was brittle, yellowed with age. The handwriting was faded but legible. OR4, General Surgeries, 09-14-2003, 21 years ago. Where did this come from? I asked, my voice steady despite the cold weight settling in my stomach. Kelly moved closer, squinting at the tag. Her face went pale. That's the old inventory system. We haven't used those tags since I started here. Then how is it on our tray? She didn't answer. Instead, she grabbed the procedural log and flipped back through entries, her finger tracing down columns of dates and case numbers. When she found September 14th, 2003, she stopped. Her finger hovered over a single line. OR4, Emergency Exploratory Laparotomy. She looked up at me. Patient died on the table. Massive internal hemorrhage. There was an inquiry afterward. They thought an instrument had been left inside during closure, but the count came back clean. The scalpel felt heavier in my gloved hand. "Bag it," Kelly said finally. "We'll report it to management in the morning. For now, log it as a discrepancy and seal it in biohazard." I nodded, placing the scalpel in a disposal bag and sealing it with red tape. I initialed the seal, dated it, and locked it in the secure disposal bin near the scrub station. The bin was solid steel, key-locked, emptied once per week by contracted medical waste services. We finished the count. 3 scalpels, as there should have been. The 4th was sealed away. But when I updated the digital log before leaving my shift, the system flagged an error. Instrument count discrepancy. 1 over. I recounted manually. 3 scalpels in the tray, 1 in the sealed disposal bin. The system still read 4 scalpels documented, 3 scalpels accounted for. Discrepancy. Plum 1. I logged out. I told myself it was a software glitch. The next morning, I arrived at 6:15 a.m. for the early shift. The surgical wing was quiet, still caught in that pre-dawn lull when the only sounds are ventilation hums and the distant clatter of meal carts. I stopped by the staff locker room to drop off my coat and grab my coffee mug from my locker. The mug wasn't there. In its place, centered perfectly on the metal shelf, was the scalpel. The rusted handle, the yellowed tag, the red biohazard tape still sealed around the blade. My initials, my date, exactly as I'd marked it. But the disposal bin was in OR4, locked, key access only. I stood there staring at it, my breath shallow and controlled. My hand trembled slightly as I reached out, not to touch it, but to verify I wasn't imagining it. The cold fluorescent light reflected off the blade. It was real. It was here. I checked the disposal bin later that morning after my first case. I used my supervisor key card to access the locked cabinet. The bin was still sealed. The logbook showed no entries since my signature the night before. But inside the bin, the red biohazard bag I'd sealed was empty. The tape had been cut cleanly from the inside. I reported it. Of course I did. I filed an incident report with surgical services, documented the timeline, provided photographs. The response was prompt and professional. A systems audit, a review of keycard access logs, and a maintenance check on the disposal bins. Nothing irregular was found. No unauthorized access, no tampering, no explanation. The scalpel remains in my locker. I moved it to the back corner behind my spare scrubs and a box of granola bars I never eat. I don't touch it. I don't look at it unless I have to. But every morning when I open my locker, it's moved. Sometimes it's on the top shelf. Sometimes it's balanced against the door. Once it was lying across my name tag, blade aligned perfectly with the embroidered letters. The inventory system still flags a discrepancy in OR4. One instrument over every single shift. I asked Kelly if she remembered the patient from 2003 and the one who died during the exploratory laparotomy. She pulled the archived file. The patient's name was Rachel Langford. Cause of death: exsanguination due to uncontrolled hemorrhage. The inquiry noted that the surgical team had reported feeling rushed and distracted during the procedure, though no malpractice was found. The attending surgeon on that case was Dr. Brennan. He's never mentioned it. Last week I was restocking OR4 after a gallbladder removal when I noticed something odd. The instrument tray had been counted and cleared, logged and locked away. But on the stainless steel surface in the space where the scalpels had been, there was a faint outline. A residue almost like tarnish. It matched the shape of the rusted handle exactly. I wiped it down with antiseptic. The outline remained. I don't know what happens to instruments we lose. I don't know where they go when we seal them away, log them, and try to forget them. But I think some of them remember their last use. I think some of them remember the hands that held them, the incisions they made, the mistakes that were never corrected. And I think some of them come back. Not to be discarded, but to be counted. The tally must always balance. That's the rule, even if it means adding what was never supposed to return. Some protocols exist to prevent tragedy. Others exist because tragedy has already happened, and we're just counting backward from the error. I used to believe the final count was about accountability. Now I understand it's about acknowledgement of what we used, what we left behind, and what refuses to stay sealed. The instruments remember even when the reports don't. And in the operating theater, memory has a way of demanding restitution, one blade at a time. Story 2. The suction line. The suction canister whispered every name on the surgical team, in order one after another, except mine. I've worked in surgical services for 9 years, and I've learned that operating rooms have their own language. Not the medical jargon or the call and response between surgeon and nurse, but the ambient vocabulary of machines, the rhythmic hiss of ventilators, the steady beep of monitors, the low mechanical hum of suction pumps clearing the surgical field. You learn to hear the difference between normal and wrong, a change in pitch, a hesitation in rhythm. The machines tell you when something is failing long before the alarm sound. The suction line in OR3 started speaking 3 weeks ago. It was a Thursday night just past 11. We were finishing a laparoscopic cholecystectomy. Routine, low-risk, textbook execution. Dr. Whitman was steady at the scope and I was managing the field, keeping instruments ready and monitoring the suction catheter as it cleared blood and irrigation fluid from the abdominal cavity. The pump was a standard wall-mounted unit, the kind we've used for years. Reliable, quiet, efficient. It pulls at a controlled negative pressure, just enough to keep the visual field clear without traumatizing tissue. You set it, check the gauge, and forget about it. But halfway through the procedure, the tubing rattled. It was subtle at first, a vibration against the metal rail where the line was clipped. I glanced at the gauge. Pressure was normal. Flow was steady. But the tubing continued to shake, harder now, like something was pulling against the current. "Suction's acting up," I said quietly, adjusting the catheter angle. Dr. Whitman didn't look up from the scope. "Check the canister." I moved to the wall unit and inspected the collection canister. It was half full, well below the shutoff sensor. The seal was intact. But the tubing, clear, ribbed, standard medical grade, was vibrating in my hand, and the sound it made was wrong. It wasn't mechanical, it was rhythmic, drawn out, like breath being pulled through a narrow passage. I turned down the pressure slightly. The rattling stopped. For about 10 seconds. Then it came back, harder, faster, and the canister began to fill, even though Dr. Whitman wasn't irrigating. The gauge climbed past normal range, the needle edging toward the red. I reached for the shutoff valve. But before I could turn it, the anesthesiologist, Dr. Peterson, a calm, methodical man in his 50s, called out from the head of the table. "Patient's breath sounds are off." I looked up. The ventilator was cycling normally, but Peterson was frowning, stethoscope pressed against the patient's chest. He adjusted the tube position slightly, listened again, then looked at me. "Is suction running?" "Yes, but it's only on the field. Disconnect it." I didn't argue. I reached for the tubing connection and twisted it free from the catheter. The moment the seal broke, the suction pump gave a sharp mechanical gasp, and the patient exhaled. It wasn't the passive release of air from the ventilator. It was deep, deliberate, and shaped. A long, foreign sigh that resonated through the OR, too low for the patient's age and build. Everyone stopped. Dr. Whitman pulled back from the scope. Peterson checked the ventilator settings, his hands moving quickly across the dials. The patient's vitals were stable. Oxygen saturation was perfect. But the sound lingered in the air like smoke. "Did anyone else hear that?" I asked. No one answered immediately. Finally, Peterson nodded. "Probably just air escaping from the insufflation. Let's continue." We did, but I kept the suction line disconnected for the rest of the case. The next shift, I was assigned to OR3 again. Different procedure, different team. Dr. Vasquez was scrubbed in for an inguinal hernia repair, and I was circulating with a newer nurse named Emily. Standard setup. I didn't mention the suction line incident from the night before. There was no reason to. Equipment gets quirky sometimes. You report it, maintenance checks it, and you move on. But when I powered on the wall suction unit to prepare the field, the canister made a sound. Not the usual mechanical hum. A voice, low, distorted, barely audible beneath the ambient noise of the room. It said, "Whitman." I froze, my hand still on the power switch. Emily was across the room organizing the instrument tray. She hadn't reacted. I leaned closer to the canister, listening. Silence. Just the normal suction hum. I must have imagined it. Auditory pareidolia. The brain trying to make patterns out of white noise. I shook it off and finished the setup. We ran the procedure without incident. The suction line worked perfectly. No rattling, no pressure spikes, no strange exhalations. I began to relax, convincing myself that the previous night had been a fluke. A mechanical fault that maintenance had quietly corrected. But when I was cleaning up after the case, disposing of the suction tubing and preparing the canister for sterilization, I heard it again. Peterson. Then a few seconds later, Whitman. I yanked the tubing free and powered off the unit. My heart was pounding, my hands unsteady. Emily looked over, concerned. "You okay?" I nodded quickly, not trusting my voice. I sealed the canister and tagged it for maintenance review, noting auditory anomaly in the logbook. I didn't describe what I'd heard. I didn't know how. Over the next week, I heard the names again, always when the suction was running, always in the same order: Whitman, Peterson, Vasquez. Then others, colleagues I'd worked with, surgeons I'd assisted. The voices were faint, distorted, as if spoken through water or static, but unmistakable. I reported it 3 times. Maintenance inspected the unit twice, replaced the tubing, checked the motor. No faults detected. One technician suggested I was hearing vibrations resonating through the wall pipes. An acoustic illusion. He demonstrated by tapping the canister, producing a hollow echo that sounded nothing like what I'd heard. But I knew what I heard. I started tracking the names. I kept a small notebook in my scrub pocket and wrote them down every time I caught a syllable through the suction hum. Over 2 weeks, I documented 17 names, all staff members, all people who had worked in OR3 within the last 6 months, all except one. My name was never spoken. On the 15th day, during a late-night splenectomy, I heard something new. The suction was running steadily, clearing the field as Dr. Whitman worked through the splenic artery. The canister was almost full, dark red fluid swirling inside the clear plastic chamber. And then, beneath the mechanical hum, I heard it. "Where is she?" I stepped back from the table, my breath catching. Dr. Whitman glanced up briefly but said nothing. The voice continued, clearer now, cycling through the names again. Whitman, Peterson, Vasquez, Emily, like a roll call. Then, "Where is she?" She pulled the line. My hands were shaking. I reached for the shutoff valve, but before I could turn it, the suction pressure spiked. The gauge needle slammed into the red zone, and the tubing began to whip violently, spraying irrigation fluid across the sterile field. Dr. Whitman shouted something, but I couldn't hear him over the roar of the pump. I twisted the valve hard, cutting the suction entirely. The room went silent. The patient's monitor beeped steadily. The ventilator cycled. Everything was normal, except the canister. The fluid inside was still moving, swirling slowly, counter to gravity, as if something was circulating it from within. And in the center of the dark liquid, bubbles rose in steady, rhythmic pulses, like breathing. I requested a transfer out of OR3. My supervisor approved it without question, noting only that I'd been logging equipment concerns repeatedly and that a change of environment might help. I didn't argue. I didn't explain. I work in OR7 now. The suction unit there is newer, digital, with automatic pressure regulation and a quiet, efficient motor. It doesn't rattle, it doesn't whisper. But 2 days ago, I passed by OR3 during a shift change. The door was propped open and I could see the wall suction unit clearly. The canister was empty, freshly sterilized, the tubing coiled neatly on the hook. And as I walked past, I heard my name, not from the canister, from the intercom speaker mounted above the door. Soft, clear, repeated 3 times. "She's here. She's here. She's here." I didn't stop. I didn't look back. But I know now why my name was never spoken before. It wasn't calling the team, it was calling for me. And I think somewhere in the lines and chambers of that machine, something has been waiting, pulling, listening. The suction doesn't just clear the field, it remembers what it takes. We trust machines to be neutral, to pull what we direct them to pull and nothing more. But in the operating room, where breath and blood pass through tubes and canisters, where the boundary between patient and equipment dissolves into sterile connection, I've learned that some devices don't just extract, they retain, they listen, and when they call your name, it's not a malfunction, it's an invitation. The suction line knows who disconnected it, and it's still pulling, waiting to balance what was interrupted. Story 3. Operating Theater 7. When the monitors flatlined, Dr. Halford didn't stop cutting. He whispered, "Not yet." And I looked down at the patient's wristband. It had my name on it. I was transferred to Operating Theater 7 in late October, 3 weeks after returning from medical leave. The reassignment was framed as temporary, a scheduling adjustment due to staffing shortages in the surgical wing. My supervisor, Margaret, handed me the updated roster without much ceremony, her tone brisk and clinical. "You'll be covering OR 7 for the next month. Mostly elective procedures, nothing urgent. The room's been underutilized lately, so we're rotating staff through to keep it operational." I didn't ask why it was underutilized. In a hospital this size, some rooms simply fall out of favor. Equipment gets dated. Layouts become inefficient. Surgical teams develop preferences, and over time, certain theaters become secondary spaces, functional but forgotten. Theater 7 was on the north wing of the surgical floor, past the main cluster of operating rooms. The hallway leading to it was quieter than the others, the lighting slightly dimmer, the air cooler. When I pushed through the double doors on my first shift, the room felt smaller than it should have been, despite being the same dimensions as OR 4 or OR 6. The walls were the usual pale blue, the equipment standard issue, the layout unremarkable. But the lights hummed, not loudly, not obtrusively. Just a faint, persistent vibration that sat at the edge of hearing, like the hum of an old fluorescent ballast slightly out of phase with itself. I made a mental note to report it to maintenance and began my preoperative checks. The patient was scheduled to arrive at 9:00 a.m. for a laparoscopic appendectomy, routine, low risk. I prepped the instrument trays, verified the anesthesia cart, and powered on the monitors. Everything was in order. At 8:55 a.m., the patient chart arrived. I opened the file on the surgical tablet, expecting the usual pre-op documentation. Patient name, date of birth, medical history, consent forms, allergy alerts. But the screen was blank, not empty, blank, as in the fields were present, but none of them contained data. The name field showed a cursor blinking as if waiting for input. The date of birth field was similarly empty. The consent signature box displayed a gray placeholder that read, "Awaiting authorization." I frowned and refreshed the file. The screen flickered, then returned to the same blank state. "Anesthesia, are you seeing this?" I asked. Dr. Halford, the anesthesiologist assigned to the case, was across the room preparing the induction meds. He glanced over, his expression placid. "Seeing what?" "The patient chart. It's not loading." He walked over and peered at the screen. For a moment, he said nothing. Then he tapped the tablet twice, as if that would resolve the issue, and shrugged. "System glitch. We'll pull a hard copy from pre-op." "Shouldn't we delay until it's resolved?" "Patient's already in transport. We'll verify manually." His tone was final, dismissive. He returned to his station without further comment. I didn't argue. In surgical nursing, you learn to adapt quickly to technical failures. Electronic health records crash, tablets freeze. You work around it. But something about the empty fields unsettled me. Not because of the missing data, but because the fields themselves looked wrong, as if they'd never been filled in the first place. At 9:03 a.m., the patient arrived. The transport team wheeled the gurney into the theater, and I moved to assist with the transfer to the operating table. The patient was a middle-aged woman, sedated but responsive, her eyes half open and unfocused. I checked her wristband. It was blank. No name, no patient ID number, just a white plastic band sealed around her wrist, entirely unmarked. "Where's the ID label?" I asked the transport tech. He looked confused. "It's right there." I held up the wristband. "There's nothing on it." He leaned closer, squinting, then shook his head. "I see it. Jane Hollis. Dobbs 07-12-1979, same as the chart." I stared at him, then at the wristband. The plastic surface was smooth, empty, unchanged. "I don't see anything," I said slowly. The tech frowned, but didn't press the issue. "Well, it's her. We verified at pre-op. You're good to go." He left without waiting for a reply. I looked at Dr. Halford. He was checking the anesthesia machine, his back to me. I looked at the surgeon, Dr. Grayson, who was scrubbing in at the sink outside the theater. Neither of them seemed concerned. I placed the wristband back against the patient's arm and told myself to let it go. The procedure began at 9:20 a.m. Dr. Grayson made the initial incision with steady hands, calling for instruments in his usual calm, methodical cadence. I passed him the laparoscope, monitored the insufflation pressure, and kept the field clear. Everything progressed normally, except for the lights. The hum had grown louder, or maybe I was just noticing it more. It oscillated slightly, rising and falling in slow waves that didn't match any machine in the room. I glanced up at the overhead surgical lights. They were steady, bright, focused. But the hum persisted, and beneath it I could almost hear something rhythmic, a cadence, a pattern. At 9:47 a.m., the monitors flatlined, not gradually, not with alarms or warning indicators. The heart rate monitor, the oxygen saturation display, the blood pressure cuff, all of them dropped to 0 simultaneously, their screens going dark for half a second before lighting up again with flat, silent lines. I looked at Dr. Halford, expecting him to call a code, but he didn't move. He stood at the head of the table, hands resting lightly on the anesthesia cart, watching the monitors with an expression of mild interest. "Doctor," I said, my voice sharper than I intended. He glanced at me. The patient just flatlined. He looked back at the screens, tilted his head slightly, and then smiled. A small, almost absent expression. "Not yet," he said softly. I stared at him. "What?" "She's fine. Keep going." Dr. Grayson hadn't stopped cutting. His hands moved with practiced precision, separating tissue, cauterizing vessels, murmuring instructions as if nothing had happened. I looked down at the patient. Her chest wasn't rising. The ventilator was cycling, but there was no movement, no exchange. "She's not breathing," I said louder now. "She doesn't need to," Dr. Grayson replied without looking up. "We're almost done." I took a step back from the table. My hands were shaking. The room felt wrong. Too cold, too quiet despite the hum. I looked at the patient's wristband again, and this time there was text, printed clearly in black ink, patient name, Harper Elise Collins, Dobe, 03/22/1991. My name, my birth date. I reached down, touching the band with trembling fingers. It was real. The ink didn't smear. The plastic was sealed. My name, printed in standard hospital typeface, wrapped around the patient's wrist. "Dr. Grayson," I said, my voice barely above a whisper. "Stop." He didn't stop. He sutured the incision closed with smooth, efficient motions, each stitch perfectly spaced. Dr. Halford began documenting the case on his tablet, tapping entries into fields that I knew had been blank minutes earlier. I looked around the room. The lights were still humming. The monitors were still flatlined. And in the reflection of the stainless steel instrument tray, I saw something that made my breath catch. The patient on the table was me. Not similar, not a resemblance. Me, my face slack and pale under anesthesia, my hair tucked beneath the surgical cap, my body draped in blue sterile sheets. I turned back to the table. The woman lying there was still the middle-aged patient from transport, her features unfamiliar, her wristband now blank again. But in the reflection, it was me. Final count, Dr. Grayson said, stepping back from the table. All instruments accounted for. Close the chart. Dr. Halford nodded and powered off the tablet. The monitors blinked once and then resumed normal function. Heart rate steady at 72, oxygen at 98%, blood pressure normal. The patient's chest began to rise and fall again, the ventilator cycling smoothly. Dr. Grayson stripped off his gloves, disposed of them, and left the theater without a word. Dr. Halford followed, pausing briefly at the door. He looked at me, his expression unreadable. "Good work today, Harper. See you tomorrow." The door closed behind him. I stood alone in operating theater 7, staring at the empty table, the instruments still warm, the lights still humming at that wrong, oscillating frequency. I checked the tablet. The patient chart was complete now. Name, date of birth, procedure notes, consent forms, all filled in, signed, closed. The patient listed was Jane Hollis, DOB 07 and 12/1979, discharged to recovery at 10:15 a.m. I checked my own wristband, the hospital ID I wore every shift clipped to my scrub pocket. It was blank. I reported what happened. Of course I did. I went directly to Margaret's office and recounted the entire event. The blank charts, the flat-lined monitors, the wristband, the reflection. I kept my voice steady, clinical, factual. I didn't embellish, I didn't speculate. Margaret listened without interrupting. When I finished, she folded her hands on her desk and nodded slowly. "Theater 7 has a history," she said carefully. "Some staff report disorientation, unusual experiences. We've had the equipment inspected multiple times, nothing conclusive. Then why is it still in use? Because functionally it works. Patients recover. Outcomes are consistent. Whatever you experienced, whether it's environmental, psychological, or technical, it doesn't affect surgical success." I saw my name on the patient's wristband. "You were stressed. You just come back from leave. The mind can..." It wasn't stress. Margaret's expression didn't change. "I'm reassigning you back to OR 4 tomorrow. Consider the transfer complete. But Harper, if you're struggling with what you experienced, we have resources, counseling, peer support." I nodded, knowing the conversation was over. I haven't been back to Theater 7, but twice now I've received surgical schedules assigning me there. Both times, I've swapped shifts with colleagues without explanation. They take the assignments without complaint, and I never ask them about their experiences afterward. But last week I saw one of them, a nurse named Amy, standing in the hallway outside OR 7 staring at her hospital ID badge. Her hands were shaking. When I asked if she was okay, she looked at me with wide, hollow eyes. "Have you ever seen your name somewhere it shouldn't be?" she asked. I didn't answer. She held up her badge. The photo was correct. The ID number was correct. But the name field was blank. Some operating theaters aren't decommissioned because they're dysfunctional. They're kept operational because they perform a different kind of procedure, one that doesn't appear in surgical logs or patient outcomes. Theater 7 doesn't malfunction. It operates exactly as intended, and if you're assigned there, it's not a scheduling error, it's an enrollment. The surgery has already been planned. The consent has already been given. You just don't remember signing it yet. Story 4. Surgical prep. I scrubbed harder, but the antiseptic streaks kept reforming. Lines, circles, my own initials, and when I looked at my gloved hand, the same symbol glowed faintly on the latex. Surgical prep is muscle memory. After 6 years as an OR nurse, I can prep a patient's arm for IV access or an incision site without conscious thought. The motions are automatic. Tear open the antiseptic swab packet, apply the solution in overlapping circular motions starting from the center and moving outward. Allow it to dry completely before draping. The whole process takes 90 seconds. The solution evaporates quickly, leaving the skin tinted amber but dry to the touch. It always dries. Always. Except in OR5 3 nights ago when it didn't. We were prepping for an emergency fasciotomy. A compartment syndrome case transferred from the ER after a motorcycle accident. The patient was a young man in his 20s, stable but in significant pain, his right forearm swollen and mottled. Dr. Brennan was scrubbing in, and I was handling the sterile field setup. I opened the antiseptic swab and began prepping the patient's forearm, starting at the planned incision site and working outward in methodical circles. The solution spread easily, staining the skin a familiar rust orange. I set the swab aside and waited for it to dry. 30 seconds passed. The skin was still wet. I frowned and dabbed at it lightly with a sterile gauze pad. The antiseptic smeared but didn't absorb. I applied a second swab, thinking maybe the first application had been too heavy. The solution pooled slightly, then began to run in thin rivulets down the patient's arm. But not randomly. The streaks formed shapes, clean, deliberate lines that curved and intersected. A circle bisected by a vertical line with 2 smaller marks flanking it like parentheses. I blinked, leaned closer. The pattern was too precise to be accidental. It looked almost like a symbol or initials. HEC, my initials. Harper Elise Collins. I stared at the patient's arm, my pulse quickening. The antiseptic continued to move, the lines deepening, the design becoming more defined. I grabbed another gauze pad and wiped hard, scrubbing the area until the skin reddened. The streaks disappeared for about 5 seconds. Then they reformed. Same pattern, same initials. Problem? Dr. Brennan's voice came from behind me. He was gowned and gloved, waiting at the edge of the sterile field. The prep isn't drying, I said, keeping my voice steady. He stepped closer, glanced at the patient's arm. Looks fine to me. Let's drape. I looked down. The skin was dry. No streaks, no symbols, just the standard amber tint of antiseptic solution. Right, I said quietly. Sorry. We draped the patient and began the procedure. I told myself it was fatigue, a trick of the overhead lights, a smear of solution catching the angle wrong. But when I glanced at my gloved hands a few minutes later, I froze. On the palm of my right glove, faint but visible under the surgical light, was the same symbol. The circle, the line, the initials, HEC. I clenched my hand into a fist, hiding it. My heart hammered against my ribs. Dr. Brennan was calling for sutures, his voice calm and focused. I passed the instruments mechanically, my movements automatic, but my eyes kept drifting back to my glove. The symbol didn't fade. If anything, it grew clearer, as if the latex itself were developing the image from within. After the case, I stripped off my gloves and examined my hands under the scrub sink light. My palms were clean. No marks, no residue. I checked my left hand, then my right, turning them over slowly. Nothing. I washed thoroughly, dried my hands, and told myself to let it go. The next night, I was assigned to a different OR, the cholecystectomy in OR2. Routine gallbladder removal, different patient, different surgeon, different setup. I prepped the patient's abdomen for the laparoscopic ports, applying the antiseptic in the same methodical pattern I always used. It didn't dry. The solution pooled, then spread, forming the same design. Circle, line, initials. This time I didn't wait. I grabbed a fresh gauze and scrubbed the area immediately, pressing hard enough that the patient's skin blanched under the pressure. The marks disappeared and reappeared. I tried a different antiseptic solution, same result. I tried prepping a different area of the abdomen. The marks followed. "Collins, we're ready," Dr. Vance said from across the room, her tone clipped. I nodded, forced myself to breathe evenly, and draped the patient. The surgery proceeded without incident, but twice during the procedure I caught sight of my gloves under the light, both palms now marked with the same faint glowing symbol. I said nothing. On the third night, I was prepping a patient for a hernia repair when the circulating nurse, a veteran named Rita, noticed me hesitating over the antiseptic tray. "You okay?" she asked. "Fine," I lied. "Just checking the expiration date." She gave me a long look, then glanced down at the patient's skin where I'd just applied the prep solution. Her expression shifted, not alarmed, but knowing. Weary. "You see it too," she said quietly. I looked at her sharply. "See what?" "The marks, the patterns." She gestured toward the patient's abdomen where the antiseptic had once again formed the same symbol. They started showing up about 2 months ago. Different staff, different patients, always the same design. Always initials. "Why didn't anyone report it?" Rita shrugged. "We did. Maintenance checked the solution batches, no contamination. Infection control reviewed the protocols, nothing irregular, so we stopped talking about it. But you still see it. Every shift." She met my eyes. "Do you know what it means?" I shook my head. "Neither do I, but I know 3 nurses who've transferred out of surgical services in the last 6 weeks. They all worked in the ORs where it happens most." She paused. "And they all had the marks show up on their own skin eventually." "What do you mean, their own skin?" Rita pulled back her scrub sleeve, revealing her forearm. Just below her wrist, faint but unmistakable, was the same symbol I'd seen on the patient's arm, on my gloves. But this wasn't antiseptic. It was embedded in her skin. Not a tattoo, not a scar, but something in between. A mark that looked like it had always been there. "It doesn't wash off," she said, "and it doesn't fade." I stared at her arm, my mouth dry. "Check your wrist tonight," Rita said, "under a strong light. If you've been seeing the marks for more than 2 shifts, it's probably already there." I didn't wait until night. During my break, I went to the staff restroom and rolled up my sleeve under the fluorescent lights. My left wrist was clean. My right wrist, the symbol was there, faint, barely visible but present. The circle, the line, the initials that weren't quite initials anymore. They'd shifted slightly, become more abstract, more intricate. I traced the mark with my finger. It didn't hurt. It didn't itch. It was just there. Part of my skin now, as if it had been etched in slowly, layer by layer, every time I prepped a patient, every time I saw the pattern reform under the antiseptic solution. I pulled my sleeve down and returned to the OR. I still see the marks during prep. Every patient, every procedure. The antiseptic no longer dries the way it should. The symbols form, and I've stopped trying to scrub them away. The other nurses see them too, though we don't discuss it anymore. The mark on my wrist has grown clearer. It's visible now even without strong light. When patients notice it, and some do just before they go under, they ask what it means. I tell them it's a birthmark. They usually accept that. But last week, a patient, an older woman scheduled for a knee replacement, looked at my wrist and then at her own prepped surgical site. She saw the matching symbol forming in the antiseptic streaks on her skin. "You're marked, too," she whispered, her voice slurred from the sedation. "It's just the prep solution. I said softly. She shook her head, her eyes unfocused but intent. No, it means you're next. Surgical prep is supposed to sterilize, to remove what doesn't belong and create a clean field for the procedure. But some marks aren't contamination, they're identification. And once the antiseptic begins to recognize you, once it writes your initials in its refusal to dry, you're no longer preparing the patient, you're being prepared. The field is set, the instruments are ready. And somewhere in the hospital's GE, your procedure has already been scheduled. Story 5. The Call Light. The intercom crackled with my voice, calm, precise, ordering instruments I hadn't called for yet. And the timestamp read 11:47 p.m. My watch said 11:26. Operating rooms have emergency call systems hardwired into their design. A red button on the wall, easy to reach in crisis, connected directly to the surgical desk and security. Press it and help arrives within 90 seconds. In 8 years of surgical nursing, I've pressed it twice. Once for a patient coding during a routine procedure. Once when a surgeon collapsed mid-operation from an undiagnosed arrhythmia. The system is simple, reliable, and never activates on its own. Until OR9. The room had been offline for 3 months due to renovations, outdated equipment removal, new monitoring systems installation, updated ventilation. The construction was finished 2 weeks ago, but scheduling hadn't assigned any cases there yet. It sat empty, dark, and locked, waiting for final inspections and certification. I was working a late shift in OR4, assisting Dr. Lindholm with a complex spinal fusion, when the emergency call light for OR9 began flashing on the overhead alert panel. Red, insistent, silent. I noticed it first during a lull in the procedure when Dr. Lindholm was repositioning retractors and I glanced up at the panel to check our room status. OR9's indicator was pulsing, the emergency designation clearly marked. Security, this is OR4, I said into my headset. We're showing an emergency call from Theater 9, can you verify? There was a pause, then the security officer's voice came through, professional and slightly confused. OR9 is unoccupied. I'll check the system. Copy. I returned my attention to the surgical field. Dr. Lindholm was calling for the next set of screws. I passed them, monitored placement, kept the routine moving. But my eyes kept drifting back to the alert panel. The light was still flashing. 5 minutes later, security called back. Collins, we've checked the room. Doors are locked, lights are off, no one inside. Might be a wiring issue from the renovation. I'll file a maintenance request. Understood, thanks. The light continued flashing for another 12 minutes, then stopped. I didn't think much of it at the time. Post-construction glitches are common. Sensors misfire, connections short, alarms trigger without cause. Maintenance would trace the circuit and resolve it. But at 11:26 p.m. during the final closure phase of the spinal fusion, the intercom in OR4 crackled to life, and I heard my own voice. Not a recording, not an echo. My voice clear and calm, speaking words I hadn't said yet. Dr. Lindholm, I need a medium Penfield dissector and 2 more retractors for the left approach. Suction is reducing visibility, also increase pressure by 15%. I froze, my hands hovering over the instrument tray. Dr. Lindholm looked up, frowning. Did you just say something? I shook my head, my throat tight. No. I thought I heard... He paused, listening. The intercom was silent now. He shrugged and returned to the closure. Never mind. Let's finish up. But I'd heard it. My voice, my cadence, my exact phrasing. And worse, the instruments I'd mentioned weren't for this procedure. They were specialized neurosurgical tools we hadn't used tonight. I glanced at the intercom panel. The indicator light showed the transmission had come from OR9. I keyed my headset again. Security, the intercom in Theater 9 just broadcast into OR4. Can you confirm the room is still empty? Another pause. Checking now. I waited, my pulse thudding in my ears. Dr. Lindholm was placing the final sutures, his hands steady and practiced. Around me, the OR hummed with its usual ambient noise, ventilator cycles, monitor beeps, the soft whir of the surgical lights. Security's voice returned. Room is still locked and dark, no signs of entry. The intercom system for that room should be powered down. I'm not sure how it transmitted. Can you check the timestamp on the transmission? Hold on. A longer pause then. Showing 11:47 p.m. I looked at my watch. 11:29 p.m. That's 18 minutes from now, I said slowly. Must be a system error. I'll escalate this to IT. The intercom crackled again. Suction pressure is good, yo. Dr. Lindholm, we're ready for final irrigation and count. My voice. Future tense. Instructions I would give in approximately 12 minutes once Dr. Lindholm finished the suture line and prepared for the final sterile rinse. Dr. Lindholm stopped mid-stitch. Okay, I definitely heard that. Was that you? No. But it sounded... I know. We both stared at the intercom speaker mounted on the wall. It was silent now, the red transmission light dark. Where did that come from? Dr. Lindholm asked, his voice quieter. Theater 9. The room that's been closed for 3 months? I nodded. He set down his needle driver carefully, his expression unreadable. Let's finish this case. We completed the procedure in near silence. Dr. Lindholm worked methodically, his usual steady demeanor intact but his eyes occasionally flicking toward the intercom. I provided instruments and maintained the field, but my mind was elsewhere, tracking the timestamps, counting down the minutes. At 11:43 p.m., the intercom activated again. Final instrument count, 22 clamps, 18 retractors, 6 dissectors, all accounted for. Closing the surgical site now. That was 4 minutes ahead. We hadn't started the count yet. But when we did, at exactly 11:47 p.m., I spoke those exact words in that exact order without realizing it until I'd finished. Dr. Lindholm's hands stilled. He looked at me, his face pale under the surgical lights. Collins, he said quietly, what the hell is happening? I didn't answer. I didn't have one. After the case, I went directly to OR9. The hallway leading to it was dark. The overhead lights dimmed for night shift energy conservation. The door was locked, as security had reported, but I had a master key card for all surgical theaters. I swiped it, heard the lock disengage, and pushed the door open. The room was cold, empty. The equipment had been removed, leaving only bare walls and the skeletal framework of mounting brackets and outlet panels. The surgical lights were dark, the monitors disconnected. No power, no activity, but the intercom panel on the wall was lit, not brightly. Just a faint green indicator light showing the system was active. I crossed the room and examined it. The panel was standard issue, identical to every other OR in the facility. 3 buttons: transmit, receive, emergency. The emergency button was slightly depressed, as if someone had pressed it, and it hadn't fully released. I pressed it fully, then released it. The button returned to its normal position with a soft click. The intercom crackled. Collins, are you there? My voice. But not from earlier tonight. This was different. Strained, urgent, breathless. If you're hearing this, you need to leave Theater 9. Don't come back. Don't check the timestamps. Don't... Static consumed the transmission. I waited, my breath shallow, my hand hovering over the panel. The intercom cleared. You're already here, aren't you? You heard yourself and came to check. That's what I did. That's what we always do. I stepped back from the panel, my skin prickling with cold. The loop doesn't start in the room. It starts when you hear your own voice giving orders you haven't given yet. Once you hear it, you're part of the sequence. And the room records it. Every version. Every iteration. The green light on the panel began to pulse, slow and rhythmic. Check the timestamp, Collins. Check it now. I pulled out my phone and opened the security app, accessing the facility's intercom log. The most recent transmission from OR9 was listed at the top. Time, 12:03 a.m. I looked at my watch, 11:54 p.m., 9 minutes from now. You're going to try to leave. You're going to walk out of this room and tell yourself it's a malfunction. But at 12:03, you'll key the intercom from OR4. You'll transmit into this room, and I'll hear you. The version of you 9 minutes behind. My hand was shaking. I reached for the door. There's no way out of the sequence once it starts. Every time you hear yourself, you create the moment you heard. The room records it, stores it, loops it. I opened the door and stepped into the hallway. The lights flickered once, then stabilized. Behind me, the intercom crackled one last time. See you in 9 minutes. I went back to OR4. I didn't transmit anything. I turned off my headset, disabled the intercom panel, and sat in the staff lounge until my shift ended at 1 a.m. But when I checked the security log the next morning, there was a transmission recorded from OR4 to OR9 at exactly 12:03 a.m. Audio file attached. I played it. It was my voice, calm and professional. Security, I'm checking on the intercom malfunction in Theater 9. Disregard previous alerts. System is functioning normally. I don't remember saying that. I don't remember keying the intercom at all, but the timestamp doesn't lie. And when I checked the log for OR9's response, the one I should have heard if I'd been listening, the playback was my own voice again. Collins, are you there? Time, 11:55 p.m., 8 minutes before I transmitted. I've requested a transfer out of the surgical wing. My supervisor approved it with surprising speed, as if she'd been expecting the request. I start in outpatient services next week. No operating rooms, no intercoms, no emergency call lights. But 2 nights ago, I received a text message from an unknown number. No words. Just a timestamp. 11:26 p.m. and an audio file. I haven't opened it yet. I know what it will contain. Emergency systems are designed to call for help when something goes wrong in the present. But in Theater 9, the call light doesn't flash for what's happening now. It flashes for what's already been recorded. 20 minutes ahead, 9 minutes behind. A sequence that loops back on itself, pulling you into the transmission log whether you speak or stay silent. The intercom doesn't malfunction, it archives. And once your voice is stored in the system, it doesn't matter when you said it. The room will play it back on schedule. You'll hear yourself calling for help, and you'll answer. You always do. Story 6, Retained Object. The radiologist's voice was calm, almost clinical. There's a metallic object visible in your chest cavity. Looks like a surgical clamp. When was your last operation? I'd never had surgery in my life. Retained surgical objects are every operating room's nightmare. A sponge left in the abdomen, a needle fragment embedded in tissue, a clamp forgotten during closure. It's rare, 1 in every 5,000 procedures, but when it happens, the consequences are severe. Infection, obstruction, litigation, and the systematic destruction of a surgical team's credibility. That's why we count. Obsessively. Multiple times per procedure. Every instrument, every sponge, every needle. Before we start, during critical transitions, and before closure. The counts are documented, verified, and signed off by at least 2 staff members. In 10 years of surgical nursing, I've never had a count discrepancy that wasn't immediately resolved. Until 3 weeks ago. The audit began on a Tuesday morning. I arrived at the surgical wing to find our department manager, Patricia, waiting outside OR 6 with a clipboard and 2 representatives from risk management. Her expression was tight, professional, but beneath it I could see the tension. "Collins, we need to speak with you about a case from last month." I followed them to a conference room, my mind already running through recent procedures, searching for anything irregular. Patricia slid a printed case file across the table. "August 14th, exploratory laparotomy, OR 6. You were the circulating nurse. Dr. Mendez was the attending surgeon." I remembered the case. A middle-aged man with suspected bowel obstruction, routine exploration, unremarkable outcome. The patient had recovered well and been discharged 4 days later. "What's the issue?" I asked. Inventory audit flagged a missing cryol clamp from that case. The initial count logged 5 clamps opened and used. The final count logged 5 clamps accounted for. But when we cross-referenced against the disposal and sterilization records, only 4 clamps were processed post-op. I frowned. That's not possible. I verified the final count personally. Everything was accounted for. "We're not suggesting negligence," one of the risk management reps said carefully. "But we need to conduct a thorough recount and review its standard protocol." We spent the next 4 hours reconstructing the procedure. We pulled the original instrument trays, reviewed the video footage from the OR camera system, checked disposal logs, sterilization records, and supply inventories. We interviewed every staff member present during the case. The conclusion was unanimous. 5 clamps had been opened. 4 had been processed post-op. 1 was missing. "Could it have been misplaced during disposal?" I asked. "Accidentally placed in the wrong bin?" Patricia shook her head. "We've checked every disposal container from that day, every sterilization batch, every supply closet, nothing." "What about the patient? Did we image him post-op?" "Standard post-operative X-ray showed no retained objects. He's been asymptomatic since discharge." She paused, her tone softening slightly. "Collins, I know your record. This isn't about blame, but we need to locate that clamp. If it's somewhere in the hospital, we find it and close the loop. If it's..." She didn't finish the sentence. "If it was retained in the patient, we were looking at a surgical recall, revision surgery, and a legal nightmare." "I'll retrace everything," I said. "I'll find it." I started with the OR itself. I spent my lunch break in OR 6, going through every cabinet, every drawer, every storage shelf. I checked under equipment carts, behind sterilization units, inside the soiled linen hampers. I moved methodically, quadrant by quadrant, refusing to leave any space unexamined. Nothing. That night, I reviewed the surgical footage again at home, watching the entire procedure frame by frame. I counted each clamp as it was handed to Dr. Mendez, tracked its use, watched it return to the tray. 5 clamps, 5 uses, 5 returns. At the end of the footage, during the final count, I watched myself touch each instrument with my pen, calling out the tally. My voice was clear, confident. 5 clamps, all accounted for. But when I paused the footage and zoomed in on the tray, I could only see 4. I rewound and watched again. 5 uses throughout the surgery. 4 on the tray during the final count. The 5th clamp disappeared somewhere between the last use and the final verification. But that was impossible. I was watching the entire sequence. There was no gap, no moment when I looked away, no opportunity for an instrument to vanish. Yet it had. 2 days later, I began experiencing an ache in my chest. It started subtly, a dull, persistent pressure just left of my sternum, like a muscle strain or tension from stress. I attributed it to the anxiety of the audit, the long hours of searching, the weight of professional scrutiny. I took ibuprofen and tried to ignore it, but the ache intensified. By the end of the week, it had become sharp, localized, almost surgical in its precision. It didn't worsen with movement or breathing. It simply existed, constant and centered, as if something foreign were pressing against my ribcage from the inside. On Saturday morning, I went to the emergency department. The attending physician was someone I knew, Dr. Carver, a competent and thorough clinician who'd worked in our hospital for years. I explained the symptoms, kept my tone clinical and detached, minimizing the discomfort. Probably costochondritis, he said after a brief physical exam. Inflammation of the rib cartilage, common with stress. But let's get a chest x-ray to be safe. I lay on the cold table in radiology, arms above my head, breathing on command as the technician captured the images. The process was routine, mechanical, and I found myself counting the seconds, focusing on the rhythm to distract from the ache. 20 minutes later, Dr. Carver called me into his office. His expression had changed, no longer casual, no longer reassuring. He pulled up the X-ray on his monitor and rotated the screen toward me. "Harper, when was your last surgical procedure?" I stared at the image. My rib cage was clearly visible, the bones bright white against the gray-black of soft tissue. And there, positioned between the fourth and fifth ribs on the left side, directly over my heart, was a small, dense, unmistakably metallic object. A surgical clamp. "I've never had surgery," I said, my voice distant, detached, as if someone else were speaking. Dr. Carver zoomed in on the object. It was a cryo clamp, identifiable by its distinctive shape. The curved jaws, the ratcheted handle, the locking mechanism. It was positioned with eerie precision, aligned perfectly with my cardiac silhouette. "This is..." "I don't understand," he said slowly. "You're saying you've never had a thoracic procedure? No cardiac surgery, no trauma repair? Nothing. Then how..." "Can you tell how long it's been there?" I interrupted. He studied the image, his frown deepening. "There's no significant inflammatory response visible. No encapsulation, no fibrosis. If this had been inside you for more than a few days, we'd see tissue reaction. But this looks recent." I thought of the audit, the missing clamp, the date of the surgery, August 14th. Today was September 7th, 24 days. "I need a CT scan," I said, "full thoracic series." The CT confirmed what the X-ray had shown. The clamp was real, metallic, and positioned within my chest cavity, just anterior to the pericardium. It was not embedded in tissue, it was not attached to any structure. It was simply there, as if it had been placed deliberately during a procedure I'd never undergone. The radiologist, a woman named Dr. Henley, pulled me aside after reviewing the images. "Harper, I have to ask, is there any possibility you had surgery and don't remember? Anesthesia, amnesia? A procedure during a trauma event?" "No, because what I'm seeing is consistent with a retained surgical object from an open thoracic procedure, but you're symptomatic and mobile, which shouldn't be possible if this was placed without surgical access. Could it have migrated from another site?" She shook her head. "Clamps don't migrate. They're too large, too rigid. If this were in your abdomen and perforated through the diaphragm, you'd be septic and unstable. This is..." She paused, choosing her words carefully. "This doesn't make medical sense. Can you remove it? We'll need to schedule a thoracoscopy, minimally invasive, camera-guided retrieval. But Harper, before we do that, we need imaging from multiple angles and a full surgical history review. If there's even a chance this is from a previous procedure, we need to document it thoroughly." I nodded, numb. I returned to work the next day and went directly to the storage room where we kept archived surgical instruments awaiting disposal or refurbishment. I found the batch from August 14th, still sealed in biohazard bags, tagged and logged. I counted the cryo clamps. 4. I pulled the inventory sheet. 5 had been checked out for the procedure. 4 had been returned. I looked at the X-ray image on my phone, the clamp in my chest, clear and undeniable. Then I looked at my own hands, the hands that had counted the instruments that day, that had verified the tally, that had signed off on the final log. I remembered touching each clamp with my pen, counting aloud, watching Dr. Mendez use them, watching them return to the tray. 5 uses, 4 clamps accounted for, 1 inside me. The thoracoscopy was scheduled for the following Monday. Dr. Mendez himself volunteered to perform the retrieval, his face pale and drawn when he reviewed the scans. He didn't ask how it had happened. He didn't speculate. He simply scheduled the OR time and assured me the procedure would be straightforward. But the night before the surgery, I received a call from Patricia. "Collins, we've located the missing clamp." I sat up in bed, my heart pounding. "Where?" "It was in OR6. Maintenance found it behind the wall-mounted sharps container during a routine inspection. It must have fallen into the gap during cleanup." "You're sure it's the right clamp?" "Inventory tag matches. It's been there since August." I looked down at my chest, at the faint bruising over my ribs from the CT scan positioning. "Patricia, if the clamp was in OR6 this whole time, then what's inside me?" There was a long silence. "I don't know," she said finally, "but we're going to find out." The surgery was performed under general anesthesia. I don't remember the procedure, only the prep. The cold OR table, the bright lights, the calm voices of my colleagues as they positioned me, draped me, verified my identity. When I woke in recovery, Dr. Mendez was sitting beside my bed. He held a small stainless steel tray. On it, sealed in a specimen bag, was the clamp. "We retrieved it," he said quietly. "No complications. Clean extraction." I looked at the clamp through the clear plastic. It was identical to the others we used. Same size, same design, same manufacturer. Except for one detail. Engraved on the handle in small, precise lettering were 3 initials. HEC. My initials. "Where did that come from?" I whispered. Dr. Mendez shook his head. "It wasn't there when we opened you. I checked the instrument before we started. The handle was blank." He paused. "But after we removed it, the engraving appeared. Like it had been there all along." I stared at the clamp, my chest aching despite the anesthesia still dulling the pain. "What does it mean?" I asked. He didn't answer, because neither of us knew. I returned to work 3 weeks later. Cleared for full duty, the thoracoscopy incisions healed to faint pink lines. The clamp was sent to pathology, then to materials analysis, then to risk management, where it remains filed under unresolved equipment anomaly. But last week, during a routine appendectomy in OR6, I performed the final instrument count. 22 instruments opened, 22 instruments accounted for. Except when I reviewed the footage later, I counted 23 on the tray. The extra instrument was a cryo clamp. And when I zoomed in on the handle, I could just barely make out the engraving. Initials. Not mine this time. Someone else's. Someone else on my team. We count instruments to ensure nothing stays behind when we close the incision. But some objects don't wait to be forgotten. They mark themselves, engrave themselves, and migrate from tray to tissue without ever being placed. The count might be perfect. The logs immaculate, the closure clean. But the instruments remember who counted them. And when the tally doesn't match, they don't vanish into disposal. They relocate. One clamp, one body, one set of initials at a time. The audit never closes, it just transfers to the next name on the list. Story 7. Sterile Field. I lifted the corner of the drape, just an inch, and saw the incision. Perfectly sutured, edges sealed. my initials stitched into the closure line. We hadn't made the first cut yet. The sterile field is sacred territory. In 10 years as an OR nurse, I've learned that this principle is absolute. Once the drape is placed over the patient, nothing unsterile crosses that boundary. No hands, no instruments, no contamination of any kind. The blue fabric creates a controlled environment where the surgeon operates with the assurance that everything within that space is clean, verified, and intentional. We drape the patient after prep and positioning, covering everything except the planned surgical site. The fabric is placed with methodical precision, unfolded carefully, smoothed to eliminate wrinkles. Once it's down, it doesn't move until the procedure is complete. It especially doesn't move on its own. I was assigned to OR 8 for a straightforward inguinal hernia repair. The patient was a man in his early 50s, healthy, no complications anticipated. Dr. Portman was scrubbed in, and I was managing the sterile field with a newer circulating nurse named Ben. We'd prepped the patient's lower abdomen, positioned him supine, and verified all equipment. Dr. Portman was reviewing the operative plan with anesthesia while I prepared the draping sequence. I unfolded the primary drape, a large blue sheet with a fenestrated opening for the surgical site, and positioned it carefully over the patient's torso. Ben assisted from the non-sterile side, making sure the edges didn't touch the floor or the patient's unprepped skin. The drape settled smoothly, covering the patient from chest to thighs. The planned incision site was centered perfectly in the fenestrated opening, the prepped skin visible and ready. And then something moved beneath the drape. Not a large movement, not a spasm or twitch, just a subtle shift. A ripple in the fabric over the patient's abdomen as if something underneath had adjusted position slightly. I froze, my gloved hand still resting on the drape's edge. "Did you see that?" I asked. Ben looked up from his tablet where he was logging the start time. "See what?" "The drape. It moved." He glanced at the patient, then at me. Probably just the ventilator cycle. Sometimes the chest movement shifts the fabric. I looked at the drape again. It was still now, perfectly smooth, no further movement. But the ripple I'd seen had been lower. Over the abdomen, not the chest. "Maybe," I said quietly. Dr. Portman approached the table, gloved hands raised, ready to begin. "Let's get started. Scalpel." I reached for the blade but hesitated. My eyes were drawn back to the drape, to the section covering the planned incision site. Something felt wrong. Not visibly, not objectively. Just an instinctive unease that prickled at the back of my mind. "Collins?" "Scalpel," Dr. Portman repeated, his tone patient but expectant. I passed the instrument. He positioned the blade over the fenestrated opening, preparing for the initial incision. But before he could cut, the fabric moved again. This time it was unmistakable. A clear, deliberate shift. The drape lifting slightly, then settling as if something beneath it had drawn a breath. But the patient was under general anesthesia. Paralyzed. Ventilator controlled. There should be no independent movement. "Doctor," I said carefully, "the patient is moving under the drape." Dr. Portman paused, blade hovering. He looked at the anesthesiologist, Dr. Kern, who was monitoring vitals from the head of the table. "Vitals are stable," Dr. Kern said. "No spontaneous respiration. Paralytic is effective." "Then what?" Dr. Portman started. The drape moved again. This time the movement was more pronounced, a bulge forming briefly under the fabric, then flattening. It happened directly over the planned incision site, as if the skin beneath were swelling and subsiding. But the monitors showed no change. Heart rate steady, blood pressure normal, oxygen saturation perfect. "Pull the drape back," Dr. Portman said, his voice calm but firm. "Let's check the site." I reached for the edge of the drape, gripping the sterile border carefully. My pulse was loud in my ears. I lifted the corner, just an inch, just enough to glimpse the skin beneath. And I saw the incision. It was already there, a clean, precise cut, approximately 4 inches long, running vertically over the inguinal region. The edges were approximated, sutured with meticulous care. Interrupted stitches, evenly spaced, the knots tied perfectly. And at the top of the closure line, worked into the sutures in a cursive looping pattern, were 3 letters. H-E-C, my initials. I dropped the drape and stepped back, my breath shallow. "What is it?" Dr. Portman asked. I couldn't answer. I stared at the draped patient, my mind refusing to process what I'd just seen. We hadn't made an incision, we hadn't even started. The scalpel in Dr. Portman's hand was still sterile, unused, untouched by tissue. "Collins, what did you see?" I forced myself to speak. There's already an incision. It's closed. Sutured." Dr. Portman looked at me like I'd spoken a different language. Then he stepped closer and lifted the drape himself, pulling it back far enough to expose the entire surgical site. The skin was intact, smooth, unmarked. The antiseptic prep stain was still visible, the planned incision line marked in sterile ink exactly as it should be. "There's nothing there," Dr. Portman said slowly. He looked at me, his expression shifting from confusion to concern. "Are you feeling all right?" I stared at the unblemished skin. "I saw... You've been working a lot of overtime lately," he said gently. "Why don't you take a break? Ben can cover the field." I wanted to argue. I wanted to lift the drape again to prove I wasn't imagining it. But I nodded and stepped away from the table, my hands trembling. Ben took my place and the procedure continued. I stood near the back of the OR, watching from a distance as Dr. Portman made the incision. The real incision, the first one, the blade cutting cleanly through skin and subcutaneous tissue. But as he worked, I kept staring at the drape, at the way it lay across the patient's body. And I swear, just for a moment, I saw the faint outline of sutures beneath the fabric. A pattern. Letters. My initials. After the case, I reviewed the surgical site photographs that are taken routinely at the start and end of every procedure. The before image showed clean, unbroken skin. The after image showed the fresh incision, properly closed, standard suture pattern. No initials, no cursive script. I checked the patient's chart. The surgery had been completed without complications. Standard hernia repair, routine closure. He was recovering well in post-op. But when I pulled up the high-resolution version of the post-operative photograph and zoomed in on the suture line, I saw something that made my stomach drop. The stitches weren't perfectly uniform. At the superior aspect of the incision, the suture spacing was irregular. Not sloppy, but deliberate. The pattern formed shapes, curves, letters, H-E-C, subtle. Almost invisible unless you were looking for it. But there. I filed an incident report describing what I'd seen under the drape. I kept my language clinical, factual, non-speculative. I noted the time, the circumstances, the sequence of events. The report was reviewed by my supervisor and then archived with a note. Perceptual anomaly attributed to fatigue. Staff counseling recommended. I didn't push back. What could I say? That I'd seen a surgical closure before the incision was made. That my initials had been stitched into a patient's skin in a pattern that only appeared under certain angles and magnifications. It sounded absurd even to me, but I haven't worked in OR 8 since. And I've started checking surgical site photographs more carefully now, zooming in, studying the suture lines, looking for patterns that shouldn't be there. Last week I found another one. Different patient, different surgeon, different OR. But the same initials worked into the closure stitches in that same cursive script. Someone else's initials this time. A surgeon I work with frequently, I showed him the photograph. He stared at it for a long time, then looked at me with an expression I couldn't quite read. "I didn't do that," he said. "I know." "Then who did?" I didn't answer because I don't think anyone did. I think the sterile field remembers. I think the drape records what happens beneath it. Not just what we do, but what we were always going to do. The incisions we'll make, the closures we'll perform. The patterns our hands will trace. And sometimes the field shows us too early, before the first cut, before we're ready to see ourselves written into the skin. The sterile drape is supposed to protect the patient from us, from our contamination, our errors, our imperfections. But in OR8, I learned that it also protects us from seeing what's already been done. The field doesn't wait for the scalpel. It anticipates. And beneath the blue fabric, in the space between prep and incision, the future is already sutured closed. Your initials are already there, stitched into tissue that hasn't been cut yet. The drape just keeps you from looking too soon. But once you lift the corner, you can't unsee the closure. And you can't stop your hands from creating the pattern they've already completed. Story 8. The Countdown. The intercom whispered 0 and every light in the OR died, except mine. A perfect circle of white illuminating only my station, my hands, and the instruments that had started rearranging themselves. Operating rooms run on time. Every procedure is measured in minutes, segmented into phases, tracked against estimated duration. Surgeons call for time checks throughout the case. How long have we been in? What's our total time? Give me updates every 10 minutes. It's a rhythm you internalize after enough shifts. The steady march toward closure. The countdown to completion. In 12 years of surgical nursing, I've learned to read time like a second language. I know when a procedure is running long. I know when we're ahead of schedule. I know the cadence of a surgeon's voice when they're rushing, when they're comfortable, when they're concerned. But I'd never heard time count backward on its own. Until OR 11. We were finishing a complex bowel resection, a 4-hour procedure that had gone smoothly despite its intricacy. Dr. Castellano was a meticulous surgeon, unhurried but efficient, and I'd worked with him enough times to anticipate his rhythm. We were in the final phase. Peritoneal closure, fascial layer approximation, skin closure pending. At the 3-hour, 40-minute mark, Dr. Castellano called for a time check, as he always did approaching the end of a case. "Time remaining?" he asked, not looking up from the suture line. I glanced at the procedure clock mounted on the wall, a digital display showing elapsed time since incision. We typically estimate 15 to 20 minutes for closure on a case like this. "Approximately 15 minutes to completion," I said. He nodded. "Good. Let's maintain pace. Update me at 10 and 5. Standard protocol." I set a mental timer and returned my attention to the instrument tray, preparing the next set of sutures. At the 10-minute mark, I called out, "10 minutes remaining, doctor." Acknowledged. At the 5-minute mark, "5 minutes, doctor." Acknowledged. Final closure commencing. Dr. Castellano began the skin sutures, his hands moving with practiced precision. The anesthesiologist, Dr. Parveen, started lightening the sedation in preparation for emergence. Everything was routine, controlled, proceeding exactly as expected. And then, as Dr. Castellano tied off the final suture and stepped back from the table, the intercom crackled. A voice, calm, professional, unmistakably mine, said, "3 minutes remaining." I froze. I hadn't spoken. My hands were on the instrument tray, my mouth closed, but the voice had been mine, identical in tone and inflection to the time calls I'd made throughout the procedure. Dr. Castellano glanced up at the intercom speaker, then at me. "Did you just say something?" I shook my head slowly. No. Dr. Parveen looked over from the anesthesia station, frowning. I heard it too. Time check? The procedure's finished, I said, when we're closed. The intercom crackled again. 2 minutes remaining. My voice, clear and distinct, but I was staring at the speaker, my lips pressed together, verifying to myself that I wasn't somehow speaking without realizing it. Dr. Castellano pulled off his gloves with 2 sharp snaps. System malfunction. Probably playing back recorded audio from earlier in the case. I've heard of that happening with older intercom units. It was a reasonable explanation. Logical. Comforting. Except we were in OR 11, which had been fully renovated 6 months ago. New equipment throughout, including a digital intercom system with no recording capability. 1 minute remaining. The voice was slightly different this time. Still mine, but with a subtle edge. An urgency that hadn't been present in my actual time calls. It was the voice of someone counting down to something imminent, something critical. I walked to the intercom panel and checked the indicator lights. No active transmission, no incoming signal. The system showed idle status, but the countdown continued. 30 seconds. Dr. Parveen stood up from his chair, his expression shifting from confusion to unease. That's not a recording. The phrasing is different. Recordings would repeat exact phrases. He was right. I'd called out 10 minutes remaining, 5 minutes remaining, always phrasing it that way. But the voice was saying 3 minutes remaining, 2 minutes, 1 minute, a continuous countdown I hadn't performed. 20 seconds. Dr. Castellano moved toward the door. I'm calling engineering. This is 10 seconds. The lights flickered. Just once, just briefly, but enough to cast the OR into momentary darkness before the backup systems caught and restored power. 5. I looked at the patient. Still stable, monitors steady, ventilator cycling normally. 4. Dr. Parveen gripped the edge of his anesthesia card, his knuckles white. 3. I found myself counting silently along with the voice, my breath shallow, my heart rate climbing. 2. Dr. Castellano's hand hovered over the door handle. 1. Silence. We waited. 5 seconds, 10, 15, nothing happened. Dr. Castellano exhaled slowly. All right, let's get the patient to recovery and file a maintenance. 0. And every light in OR 11 went out. Not a flicker this time. Not a momentary loss of power. Complete, absolute darkness. The surgical lights, the overhead fluorescence, the equipment indicator LEDs, the monitor screens. Everything died simultaneously, as if someone had cut the main power supply to the entire room. I couldn't see my hands in front of my face, couldn't see the patient, the table, my colleagues. The darkness was total, disorienting, suffocating. Emergency power should have kicked in. Dr. Parveen's voice came from somewhere to my left, tight with controlled panic. It should have. OR 11 had redundant power systems, backup generators designed to activate within 2 seconds of a main power failure. We'd tested them during the renovation. They'd worked perfectly. But now, in the darkness, there was only silence. And then light. A single surgical lamp flickered on above my station, the instrument table where I'd been standing when the countdown reached 0. The circle of illumination was perfect, precise, encompassing only my position, the stainless steel tray, and the instruments laid out across it. Everything beyond that circle remained in absolute darkness. Collins, Dr. Castellano's voice distant and uncertain. Are you there? I'm here, I said, my voice barely above a whisper. I looked down at the instrument tray bathed in the stark white light. The surgical tools were exactly as I'd arranged them. Clamps, retractors, needle drivers, scissors. Standard post-operative layout awaiting final count and sterilization. Except they were moving. not dramatically, not violently, but unmistakably rearranging themselves, sliding slowly across the stainless steel surface with faint metallic whispers. The clamps aligned in a row. The scissors crossed at precise angles. The needle drivers formed a triangle. And in the center of the tray, spelled out by the arranged instruments, was a number, 11, the OR number, formed by two scalpels placed parallel, vertical, perfect. I stepped back from the tray, my shoulder blades hitting the wall behind me. "Collins, what's happening?" Dr. Parveen's voice, closer now, moving toward my light. "Stay where you are," I said, louder than I intended. "Don't come closer." "Why? What do you see?" I couldn't answer, because now the instruments were moving again, rearranging, forming new patterns. Letters this time, spelled out in forceps and clamps. "Next, the power's back," Dr. Castellano called out from across the room. And it was. The overhead lights blazed to life. The monitors beeped their startup sequences. The ventilator resumed its mechanical hum. Emergency power had finally activated. Or the main power had returned, I couldn't tell which. I looked down at the instrument tray. The tools were arranged exactly as I'd left them. Standard layout. Nothing moved. Nothing spelled out. The scalpels were separated, not parallel. The forceps were scattered, not forming letters. Dr. Castellano and Dr. Parveen crossed the room quickly, relief visible on their faces. "Everyone all right?" Dr. Castellano asked. I nodded, not trusting my voice. "That was, 30 seconds of total darkness?" Dr. Parveen checked his watch. "Backup power took way too long. That's a serious safety violation." Dr. Castellano was already at the door, speaking to someone in the hallway, likely security or facilities. I heard fragments of the conversation. Complete power failure, unacceptable delay, patient safety. But I was still staring at the instrument tray, at the tools that I'd watched rearrange themselves, that had spelled out messages in the darkness. I looked at the wall clock. The time was 3:47 p.m. The procedure had ended at 3:32 p.m., 15 minutes ago. The incident was investigated thoroughly. Facilities management, electrical engineering, risk management. They all reviewed the event, pulled system logs, tested circuits. Their conclusion was unanimous. No power failure had occurred. The electrical log showed continuous, uninterrupted power supply to OR11 throughout the afternoon. No voltage drops, no circuit interruptions, no backup system activation. But we were in complete darkness for at least 30 seconds, I insisted during the review meeting. The engineering supervisor shook his head. "According to every monitoring system we have, the lights never went off. You can see it here in the logs. Constant power, no anomalies. 4 people experienced it. The surgeon, the anesthesiologist, the patient care tech, and myself. We all witnessed the same thing." "We're not disputing your experience," the risk management representative said carefully. "But we can't identify a technical cause. It's possible you experienced a shared perceptual event. Psychological, environmental factors, perhaps something in the air handling system causing a group hallucination." "What about the countdown?" I asked. "The intercom recording my voice?" "The intercom logs show no transmissions during that time frame. No playback, no broadcasts, nothing." I left the meeting with a sick feeling in my stomach, not because they didn't believe me. Their careful phrasing made it clear they were trying to be diplomatic, but because the alternative explanations were somehow worse than a simple power failure. Shared hallucination, environmental toxin, mass psychological event. None of those explanations accounted for what I'd seen. The instruments moving, the messages spelled out in surgical steel. I worked 3 more shifts in OR11 over the following 2 weeks. Each time approaching the end of a procedure, I found myself tensing, listening for the countdown, waiting for my voice to emerge from the intercom. It never did. But on my fourth shift in that room, a routine gallbladder removal, as Dr. Castellano was finishing the closure, I heard something else, not the intercom, not a voice, a sound, faint, rhythmic, coming from everywhere and nowhere, like a clock ticking or a timer counting down. Just audible beneath the ambient noise of monitors and ventilators. I checked the wall clock. We had approximately 10 minutes until completion. The ticking continued, steady, relentless. I didn't mention it to anyone. I simply counted instruments, maintained the field, performed my duties with mechanical precision. But I was counting along with the ticking, matching its rhythm, waiting for it to reach zero. It never did. At least not while I was listening. Because when I checked the procedure log later, I noticed something odd. The case had been logged as completed at 2:17 p.m. But my watch, which I'd checked multiple times during closure, showed 2:32 p.m. 15 minutes difference. The same 15 minutes that had disappeared during the power failure that never happened. I transferred out of OR 11 last week. My supervisor approved the request without question, just as she had for the 3 other nurses who'd requested reassignment from that room in the past 2 months. But yesterday, I was pulled to cover an emergency case in OR 11 due to staffing shortages. A trauma resection, expected duration 2 hours. I tried to decline, but there was no one else available. Halfway through the procedure, Dr. Castellano called for a time check. "Time remaining?" he asked. I looked at the procedure clock. We'd been running for 90 minutes, approximately 30 minutes until projected completion. 30 minutes remaining, I said. He nodded and continued operating. And then the intercom crackled. A voice, calm, professional, unmistakably mine, said, 29 minutes remaining. I looked up at the speaker, my breath catching. The countdown had started again. But this time it wasn't waiting for the end of the procedure. It was counting the entire duration, minute by minute, all the way to 0. And I realized, with cold clarity, that the countdown in OR 11 had never been about the surgery. It had been about me. Measuring my time, counting down to something I couldn't see yet, something that would happen when my personal countdown reached 0. I don't know when that will be, but I know it's still running. I can hear it sometimes in the quiet moments between cases, the faint tick of a timer I can't locate, counting down, always down, never stopping. And I wonder what happens when it finally reaches 0. Not for the procedure, not for the patient, but for me. What light will remain on when all the others go dark? What message will the instruments spell out when I'm the only one left to read it? Time in the operating room is supposed to be linear, a progression from incision to closure, measured in minutes we can track and document. But in OR 11, I learned that some countdowns don't mark procedure time. They mark something more personal, more inevitable. The voice that called out minutes remaining wasn't reviewing surgery duration. It was announcing a different kind of countdown. One that started the moment I entered that room, that continues in every OR I work in now, that ticks beneath every other sound. Some timers count down to the end of a case, others count down to the end of your time calling out numbers. And you never know which countdown you're hearing until you reach 0. Story 9. Instrument Tray 9. The patient was fully anesthetized, paralyzed when she started speaking, reciting my post-op instructions word for word in my exact voice before I'd even thought to say them. Surgical instruments have lifespans. They're used, sterilized, inspected, and returned to circulation thousands of times before wear and corrosion retire them. Old trays are periodically audited, outdated tools removed, inventory updated. It's a continuous cycle of replacement and disposal that ensures every instrument in the OR meets current standards, which is why finding instrument tray 9 in the back of the supply closet was so unusual. I discovered it during a routine inventory check on a quiet Tuesday morning. The closet was in the older section of the surgical wing, a storage area we rarely accessed since the renovations had consolidated most of our supplies into the newer centralized equipment room. I was looking for extra retractors when I noticed a sealed container on the top shelf, pushed far back against the wall, covered in a thin layer of dust. The container was a standard surgical tray case, stainless steel latched with a seal verification tag attached to the handle. I pulled it down and checked the tag. Tray ID 009 sealed March 15, 2013. Contents general surgery set status sterile 11 years ago. The seal was intact, unbroken, the verification sticker faded but legible. According to protocol, sealed trays maintain sterility for a maximum of 6 months. After that, they're required to be re-sterilized, re-inspected, and re-sealed. This tray had been sitting here for over a decade, forgotten and untouched. I carried it to the processing station and logged the find with our supply manager, Catherine, a meticulous woman who'd worked in surgical services for 25 years. She examined the tray with a mixture of curiosity and disapproval. March 2013. I wasn't even working in this department yet. This should have been caught years ago during inventory audits. Should I open it? I asked. Might as well. The instruments will need to be inspected and recertified before they can be used again, assuming they're still in usable condition. I broke the seal, a satisfying snap of plastic and adhesive, and unlatched the container. The lid opened smoothly, revealing the instruments inside, nestled in their designated slots within the foam lining. They were immaculate, not just clean, not just sterile, immaculate. The stainless steel gleamed under the fluorescent lights as if the tools had been manufactured yesterday. No discoloration, no pitting, no sign of age or corrosion. The edges of the scalpels were sharp. The joints of the clamps moved smoothly, the surfaces reflected like mirrors. That's unusual, Catherine said slowly, picking up a pair of scissors and examining them closely. Instruments don't look like this after 11 years in storage. Even sealed, there's usually some oxidation, some degradation. I reached for one of the hemostats, turning it over in my gloved hands. The metal was cool, smooth, perfect. But there was something else. Something that made me pause. Engraved on the handle in tiny but precise lettering was a date. 11/08/2024. I blinked, read it again, then checked today's date on my phone. November 2nd, 2024. 6 days from now. Catherine, look at this. She leaned closer, adjusting her glasses. That's a manufacture date stamp, but that doesn't make sense. This tray was sealed in 2013. I picked up another instrument on a needle driver. Same engraving style and different date. 11/09/2024. I checked a scalpel handle, 11/10/2024. A retractor, 11/12/2024. Every instrument in the tray was marked with a date in the future, not far future, just days away. Some as close as 6 days, others as far as 10. This has to be an error, Catherine said, though her voice lacked conviction. Maybe someone was testing a new engraving system and marked these incorrectly before storage. In 2013, with dates from 2024? She had no answer for that. We documented the find, photographed the engravings, and sent a detailed report to Equipment Services and Hospital Administration. The tray was placed in quarantine pending investigation, but 2 days later, during an emergency appendectomy, we ran short on instruments. The case had complications, extensive adhesions requiring additional dissection, and we'd exhausted our primary tray. The circulating nurse, a newer staff member named Marcus, went to grab a backup set from supply. He returned with instrument tray 9. I didn't realize it immediately. I was focused on the surgical field, passing instruments to Dr. Whitmore as he worked through the adhesed tissue. But when I reached for the next clamp and felt the cool, impossibly smooth metal in my hand, I looked down. The engraving on the handle read, 11/4/2024, today's date. "Marcus," I said carefully, keeping my voice level, "where did you get this tray?" "Supply closet, second shelf. It was marked as sterile and available. This tray was supposed to be quarantined. There was no quarantine tag on it. I checked. I wanted to stop the procedure, to explain the situation, but Dr. Whitmore was in the middle of a critical dissection. We couldn't pause for an instrument concern that I couldn't even articulate properly. The tools have future dates engraved on them sounded absurd even in my own head. So I continued passing instruments, each one marked with dates spanning the next week, each one feeling slightly wrong in my hands. Not in function, but in presence, as if they existed slightly out of phase with the rest of the OR. And then, about 20 minutes into using the new instruments, something changed. The tools began to hum, not mechanically, not from vibration or contact. They simply emitted a faint, almost subliminal tone, a resonance that I felt more than heard, a frequency that seemed to bypass my ears and register directly in my bones. I glanced at Dr. Whitmore. If he noticed, he gave no indication, his focus absolute as he ligated a vessel and called for the next clamp. But I noticed, and apparently so did the patient. Because despite being fully anesthetized, paralyzed by neuromuscular blockade, intubated and ventilated by machine, the patient spoke. Not a moan or a reflexive sound. Words, clear, coherent, articulated words. Apply pressure to the incision site for 10 minutes. Change the dressing every 12 hours. Watch for signs of infection, redness, swelling, discharge. My voice, my exact phrasing, the post-operative instructions I give to every appendectomy patient during recovery. But I hadn't said anything. My mouth was closed, my attention fixed on the surgical field. And the patient was unconscious, incapable of speech. Dr. Whitmore's hands stilled. Did she just monitor the surgical site daily? Remove the dressing on day 5. Sutures will dissolve on their own within 2 weeks. The anesthesiologist, Dr. Chen, was already checking the ventilator settings, his face pale. She's fully sedated. Propofol levels are therapeutic. She shouldn't be conscious, let alone speaking. Contact your surgeon if you experience fever over 101 degrees, severe pain not controlled by prescribed medication, or any bleeding from the incision. The patient's lips weren't moving. Her jaw was slack, the endotracheal tube secured in place, but the voice was emanating from her chest, her throat, resonating through her body like she was a speaker playing back a recording. Avoid heavy lifting for 6 weeks. Gradually resume normal activities as tolerated. Schedule a follow-up appointment in 2 weeks. I set down the clamp I was holding and stepped back from the table. The instrument tray was between us and the patient, the tools laid out in precise order, and I realized that the humming sound was louder now, emanating from the tray itself. The patient continued reciting instructions. My instructions verbatim, including details I hadn't consciously formulated yet but would say during her recovery. Dietary recommendations, activity restrictions, medication schedules, all delivered in my voice, in my tone, with my cadence. Dr. Chen increased sedation, Dr. Whitmore said, his voice tight. Chen was already adjusting the propofol drip, but the patient kept speaking uninterrupted as if sedation had no effect on whatever was happening. And then she said something I'd never included in any post-op instruction set. The instruments remember what they're used for. They remember who uses them. And they remember when. The humming stopped. The patient fell silent. Dr. Whitmore finished the appendectomy in record time, his movements swift and efficient. None of us spoke beyond essential communication. When the case was complete and the patient was transferred to recovery, I collected the instruments from tray 9 and returned them to the supply closet personally. I locked the tray in a cabinet and labeled it clearly, "Do not use. Investigation pending." The patient recovered normally. She had no memory of speaking during the procedure, no awareness, no dreams, no sense of anything unusual. Her post-operative course was unremarkable. Textbook. Perfect. Except for one detail. When I provided her discharge instructions during recovery, my standard speech about wound care, activity restrictions, and follow-up, she interrupted me. "You already told me all of this," she said. I paused. "When?" "During the surgery, I remember hearing it. Not like a dream, like someone was teaching me while I was asleep. Your voice. These exact words." I forced a smile. "That's not uncommon. Sometimes patients retain auditory information during anesthesia, even when fully sedated." She nodded, accepting the explanation. But as I turned to leave, she added, "You also said something about instruments remembering. That was strange. Do you tell all your patients that?" I looked back at her. "No, I've never said that." "Oh," she frowned. "I must have imagined that part." I tried to access instrument tray 9 3 days later, intending to document the contents more thoroughly and escalate the investigation. But when I opened the cabinet, the tray was gone. I checked with supply management. No record of it being moved. I checked with Catherine. She hadn't touched it. I reviewed security footage of the storage area. The tray never left the cabinet, but it wasn't there anymore. Until yesterday. I was setting up for a routine cholecystectomy in OR6 when I opened what I thought was our standard instrument tray. The tools inside gleamed with that same impossible perfection, and when I picked up the first clamp, I saw the engraving, 11/15/2024, 8 days from now. I looked around the OR. The other staff members were prepping, unaware, going through their routines. Dr. Whitmore was scrubbing in at the sink outside. The patient was being positioned on the table. And the instruments in my hands began to hum softly, that subliminal tone resonating through my bones. I used them anyway. What choice did I have? The case was starting. The patient was draped. Dr. Whitmore was ready to begin. And halfway through the procedure, the patient started speaking. Not my voice this time. Dr. Whitmore's voice, reciting the steps of the cholecystectomy he was performing, narrating each action before he completed it, describing the next 3 moves in the procedure with perfect accuracy. "I'll dissect the cystic duct now. Then ligate with medium clips, divide between the clips." His hands paused. "I'll encounter bleeding from a small branch vessel. I'll control it with cautery." 3 seconds later, the bleeding occurred exactly as described. He controlled it exactly as narrated. The patient continued speaking in his voice, predicting every step, every complication, every decision. And Dr. Whitmore followed the script perfectly, as if he had no choice, as if the instruments in his hands were guiding him through a procedure he'd already performed. When the case ended, he stood at the scrub sink for a long time, staring at his hands. "That's never happened before," he said quietly. I didn't tell him about the tray, about the dates, about what the patient had said during the appendectomy. I just logged the instruments, sealed the tray, and carried it back to storage, where I'm sure it will disappear again, and reappear in another OR, with new dates, further into the future, waiting to be used by someone who doesn't realize they're not performing surgery, they're just following instructions the instruments recorded. Instructions from a procedure that hasn't happened yet. We sterilize instruments to eliminate the past, Bacteria, tissue, contamination, everything they've touched before. But Tray 9 taught me that some tools don't just carry memory of what they've cut. They carry memory of what they will cut. The dates aren't manufacture stamps, they're expiration dates or activation dates. And when you use them, you're not performing surgery. You're completing a procedure that's already been recorded, narrated, archived in steel and etching. The instruments don't remember, they predict. And the patients speak what the tools have already written. Post-op instructions for surgeries that haven't finished. Complications that haven't occurred yet. Your next 3 moves, whispered in your own voice before you've thought to make them. Story 10. Scrub sink. I stopped scrubbing, but in the reflection my hands kept moving. Washing, abrading, cleaning tissue from under nails I'd never dirtied. The surgical scrub is sacred repetition, 2 minutes minimum, sometimes longer depending on the procedure. You wet your hands and forearms, apply antimicrobial soap, and scrub methodically. Fingertips, palms, backs of hands, between fingers, wrists, forearms. Each area receives focused attention, counted in silent rhythm until your skin is pink and raw and sterile. After 14 years as an OR nurse, I don't think about the motions anymore. My hands know the pattern. The timer in my head is automatic. I scrub, I rinse, I enter the OR with my hands raised, and I glove up without contaminating the sterile field. It's muscle memory, reliable, consistent. Until the scrub sink in OR 12 changed the routine. It started 3 weeks ago during a pre-op scrub for a routine hernia repair. I was at the designated surgical scrub sink outside OR 12, working through my standard 2-minute protocol. The water was cool, the soap familiar, the bristles of the brush abrading my skin in comfortable, practiced strokes. At the 90-second mark, the water changed temperature. Not dramatically. Just a subtle shift from cool to warm, almost body temperature. I adjusted the faucet handle, but it was already set to the same position. The temperature change hadn't come from the tap adjustment. I continued scrubbing, mildly annoyed but not concerned. Plumbing inconsistencies weren't unusual in a building this old. But then the water changed again. Not temperature this time. Texture. It felt thicker. Slightly viscous. And when I looked down at my hands under the running water, the liquid pooling in my palms had a faint metallic tinge. I stopped scrubbing and examined the water more carefully. It was clear when it left the faucet, normal and transparent. But as it ran over my hands, it took on that subtle discoloration. Rusty, like old pipes corroding. I rinsed quickly and shut off the water. My hands looked normal, clean, no staining, just the standard pink abrasion from the scrub brush. I dried off and entered the OR, pushing the incident out of my mind, probably sediment in the pipes. I'd report it to maintenance after the case. But as I was gloving up, I noticed something odd. My hands felt wrong, not painful, not injured, just sensitive, as if the skin had been scrubbed more aggressively than I'd actually scrubbed it. Raw, tender, over-abraded. I flexed my fingers inside the gloves, feeling the unfamiliar tightness, and proceeded with the case. 2 days later, I was assigned to OR 12 again. Different procedure, different surgeon, but the same scrub sink. I approached it with mild apprehension, remembering the discolored water from before. I turned on the tap. Cool water, clear and clean. I applied soap and began the scrub routine. At the 60-second mark, I glanced up at the mirror mounted above the sink. A standard practice, verifying technique, checking for contamination on my face or scrub cap. And I saw my reflection still scrubbing, even though I'd paused to check the mirror. I was standing still, hands under the water, not moving. But in the reflection, my hands continued the scrubbing motion. Vigorous, methodical, focused. I blinked. The reflection caught up, matching my stillness. I resumed scrubbing. The reflection matched me now, synchronized. But for those 3 seconds, it had been independent. I finished the scrub quickly, shut off the water, and backed away from the sink. My hands were trembling slightly. From the cold water, I told myself. Just from the cold. The third time I felt it. I was scrubbing for an emergency splenectomy, rushing through the routine to maintain surgical schedule. My hands moved automatically through the pattern, barely conscious, focused on mentally reviewing the instrument setup I'd need to prepare. And then I felt a second pair of hands, not touching mine, not external, but using mine, operating my hands from the inside, guiding the movements, scrubbing with an intensity I wasn't directing. My fingers bent at angles I hadn't consciously chosen. The brush pressed harder against my skin than I intended. The soap spread in patterns I didn't recognize. I tried to stop, to pull my hands away from the water, but they kept moving. Kept scrubbing, kept abrading the skin with mechanical precision. In the mirror, my reflection looked calm. Professional, normal. But I could feel the wrongness, the sense that my hands belonged to someone else. That I was a passenger in my own body, watching someone else conduct the pre-op scrub using my limbs. After 2 minutes, exactly 2 minutes timed with perfect accuracy, my hands stopped. Shut off the water, reached for the towel. I dried them slowly, staring at my palms. The skin was raw, redder than it should have been. And under the fingernails of my right hand there was something dark. Not dirt, not soap residue, something organic. I picked at it carefully with the edge of the towel. It came away in small fragments. Tissue, dried blood. But I hadn't been in surgery yet. I hadn't touched a patient. I hadn't contaminated my hands with anything. I scrubbed again immediately, using a different sink down the hall. The second scrub was normal. No temperature changes, no reflection delays, no foreign material under my nails. But when I checked my hands afterward, the tissue was still there, deeper now, embedded beneath the nail beds as if it had been there for hours. I reported it to infection control. They examined my hands under magnification, took samples, ran cultures. The results came back 3 days later. Human tissue, blood type O positive. DNA analysis pending. My blood type is A negative. Possible contamination from a previous case, the infection control officer suggested. Did you handle any specimens recently? Not for 3 days, and I've scrubbed at least 20 times since then. She had no other explanation. The samples were logged as an anomaly and filed for further investigation. But I knew where the tissue had come from. It had come from whatever was using my hands at the scrub sink. I've avoided OR-12 since then. I've swapped assignments, called in favors, taken less desirable shifts, anything to prevent being assigned to that room and that sink. But yesterday, during a staffing shortage, I had no choice. Emergency bowel resection, OR-12, immediate need. I stood at the scrub sink, staring at my reflection, feeling the cold water run over my hands. And I started scrubbing. At 30 seconds, the water warmed. At 60 seconds, my reflection continued moving when I paused. At 90 seconds, I felt the other hands. Not mine, but using mine. Scrubbing with desperate intensity, clawing at skin, digging under nails, trying to get clean. Trying to remove something. And I realized with cold clarity what was happening. Someone had stood at this sink before. Someone who'd contaminated their hands beyond redemption. Someone who'd scrubbed and never felt clean. And now they were using everyone else's hands, trying to finish what they'd started, trying to wash away something that couldn't be removed. I pulled my hands from the water and looked at them. The skin was abraded almost to bleeding. My nails were cracked, and under every nail, dark organic matter had accumulated. I could feel them still, and the ghost hands, the borrowed hands, the hands that wouldn't stop scrubbing, using mine, trying to get clean. Forever trying. The surgical scrub is supposed to make you sterile, to remove every trace of contamination before you enter the OR. But at the sink outside OR 12, I learned that some contamination isn't on your skin. It's in the ritual itself. In the memory of scrubbing, embedded in water and soap and mirrors that reflect more than your present. Someone stood here once, unable to get clean, and now that inability persists, transferring from nurse to nurse, hands to hands, trying to complete a scrub that can never end. Your skin gets raw not from your own efforts, but from theirs, borrowing your fingers to continue their futile ablution. And the tissue under your nails isn't yours, it's theirs, from a surgery that went wrong, from a mistake they're still trying to wash away. Story 11. The Pager. The pager buzzed in my pocket. Report to OR 11 for emergency prep. But OR 11 had been sealed since the fire. I was standing inside it when the lights came on. Most hospitals phased out pagers years ago, replacing them with smartphone apps and digital communication systems. But our surgical wing maintained a few legacy units for backup purposes. Analog devices that worked independently of the hospital's digital infrastructure, useful during network outages or system failures. They sat in a drawer at the main surgical desk, numbered and dormant, rarely touched except during disaster drills when we tested the backup communication protocols. I'd never been assigned one in 15 years of working here, until the day I found pager 11 in my locker. It was a Monday morning, early shift. I opened my locker to store my coat and found the device sitting on top of my folded scrubs. A black rectangular unit slightly larger than a deck of cards with a small LCD screen and a belt clip. The screen showed a single line of text. Pager 11, active. I picked it up, frowning. No one had mentioned issuing backup pagers. I checked with the charge nurse at the surgical desk. Did someone put a pager in my locker? She glanced up from her computer. Pager? We haven't used those in months. Check with supply if you found one. They were supposed to be decommissioned. This one says it's active. Probably just residual battery. Toss it in the equipment return bin. I nodded, but instead of disposing of it immediately, I clipped it to my scrub pocket. I'd return it later after my first case. The device was harmless, and there was something oddly nostalgic about carrying it. A reminder of early career days when pages were constant interruptions. An hour later, it buzzed. The vibration was sharp, insistent. I pulled it out and checked the screen. OR 11 need 2 units O-neg blood. I stared at the message. OR 11 didn't exist anymore, not functionally. It had been a standard operating room until 6 years ago, when an electrical fire during a late-night procedure had caused significant damage. The room had been gutted, sealed, and marked for eventual renovation that kept being delayed due to budget constraints. No one worked in OR 11. No cases were scheduled there. The room was dark, empty, inaccessible. I walked to the surgical desk and showed the charge nurse the page. Is there any way someone's using OR 11 today? She checked the schedule, scrolling through the day's cases. Nothing listed for room 11, it's still offline. She squinted at the pager. Where did that message come from? I don't know, it just came through. Probably a system error. Old pagers sometimes receive cross-frequency interference. I wouldn't worry about it. I returned to my assignment in OR 4, dismissing the page as a technical glitch. 30 minutes later, the pager buzzed again. OR 11 need additional retractors for left approach, more specific now, more detailed. The kind of request you'd receive mid-procedure when the surgical field required unexpected adjustments. I checked the device settings, looking for an off switch or a way to clear the messages. There was no obvious control panel, just the screen and the belt clip. The messages remained displayed, unerasable. 20 minutes later, OR 11, increased suction pressure. Then, OR 11, patient vitals declining, need additional support. Then, OR 11, code blue. I was in the middle of assisting Dr. Reeves with a hernia repair when that last page came through. My hands stilled over the instrument tray, the pager buzzing insistently against my hip. "Collins, focus," Dr. Reeves said, not unkindly. I passed him the clamp he'd requested and tried to ignore the device, but it continued buzzing throughout the procedure, a steady rhythm of messages that I couldn't silence. OR 11, resuscitation in progress. OR 11, no response to epinephrine. OR 11, time of death in 47. I looked at the OR wall clock. 10:47 a.m. exactly. After the case, I went to the administrative wing and found the facilities manager, a practical man named Tom who'd worked at the hospital for 30 years. "Tom, is there any possibility someone's working in OR 11? Any renovation crew, maintenance staff, anyone?" He pulled up the room schedule on his computer. "OR 11 is sealed. No access authorized. Why?" I showed him the pager messages. His expression shifted from curiosity to discomfort. "That's odd, but it's probably just the pager picking up old messages from the system. Those devices sometimes cache transmissions and replay them randomly when the battery's failing. All these messages came through in real time over the last 3 hours. Then it's definitely a malfunction. Give it here. I'll dispose of it properly." I handed over the pager, relieved to be rid of it. The next morning, the pager was back in my locker. Same device. Same screen display, pager 11 active. But this time, there was a new message already waiting. OR 11 scheduled case. 08 Alazor prep required. I checked my watch. 7:52 a.m., 8 minutes from now. I took the pager and went directly to Tom's office. He wasn't there. I left the device on his desk with a note. "Please dispose. Device keeps reappearing." I returned to the surgical wing and started my shift in OR 3. At 8:00 a.m., every pager in the surgical wing activated simultaneously. The old units in the equipment drawer, the backup devices in the emergency supply cabinet, even decommissioned pagers that had been boxed for recycling. All of them began buzzing in unison, a discordant chorus of vibration and electronic tones. Staff members looked around in confusion as the sound echoed through the corridors. And then the messages came through, displayed on every active screen, identical and simultaneous. OR 11, case beginning, all staff report. I found myself walking toward OR 11. I didn't decide to go. My feet simply carried me there, down the corridor toward the sealed wing, past the caution tape and the no entry authorized personnel only signs. The door to OR 11 was closed but not locked. I pushed it open. The room was dark, exactly as it had been for 6 years. The walls were fire damaged, the equipment removed, the floor stained with soot and chemical residue. The surgical lights hung at odd angles, disconnected and dormant. But in my pocket, the pager buzzed again. OR 11, you're late for pre-op. I stepped inside. The moment I crossed the threshold, the lights flickered on. Not the overhead fluorescents. Those were destroyed. But the surgical lights, the impossible ones, the disconnected ones, illuminated with full intensity, casting stark white light across the burned room. And in the center of the space where the surgical table should have been, where it had been removed years ago, there was a table. Stainless steel, sterile draping, instrument trays arranged precisely, anesthesia cart positioned at the head. monitors displaying vital signs, all of it pristine, functional, impossible. The pager buzzed. OR 11, patient prep, complete, begin procedure. I approached the table slowly. The draping covered a body, the outline clearly visible beneath the blue fabric. I could see the rise and fall of breath, the shape of arms positioned at the sides, the contour of a face beneath the sterile covering. I reached for the drape's edge and pulled it back. The patient was me. My face, slack with anesthesia, my body prepped and positioned, my wrist banded with a patient ID that read Collins Harper E. Dobb, 03/22/1991. Procedure, exploratory surgeon unassigned. The monitors beside the table displayed my vital signs, heart rate, blood pressure, oxygen saturation, all within normal range, all updating in real time. But I was standing beside the table. I was conscious. I was looking down at myself. The pager buzzed one final time. OR 11, procedure commencing, remain sterile. I looked up at the surgical lights. They blazed down on the table, on the draped figure, on the instruments waiting in their trays, and in the observation window, the glass that should have been blackened and shattered. I saw faces, surgical staff in masks and gowns watching, waiting. I recognized some of them, nurses I'd worked with years ago, surgeons who'd retired, an anesthesiologist who died in a car accident 3 years prior. All of them standing in the observation deck, all of them watching the table, watching me. Both versions of me, the one standing and the one waiting for surgery to begin. I don't remember leaving OR 11. I don't remember walking back to the main surgical wing or starting my shift. But when I regained full awareness, I was in OR 3 assisting with a routine gallbladder removal, functioning normally. The pager was gone from my pocket. But when I checked my locker later, it was there again, displaying a single message. OR 11, procedure incomplete, return for closure. I threw the pager away. I disposed of it in the biohazard waste, the electronic recycling, the general trash. I left it in Tom's office, in the charge nurse's desk, in the equipment return bin. It always came back, always in my locker, always with the same message. OR 11, procedure incomplete. Last week I received a notification from scheduling. My annual health screening was coming due. Routine physical, blood work, imaging. Standard employee wellness check. The appointment location was listed as OR 11 Outpatient Services. I called scheduling to correct the error. OR 11 isn't an outpatient facility. It's not even operational. The scheduling coordinator sounded confused. According to our system, OR 11 has been active for 6 years. It's our primary location for employee health procedures. Are you sure you're thinking of the right room? I'm certain. That room was damaged in a fire and sealed. Let me pull up the records. A long pause. I'm showing continuous operations since 2018. No interruptions. No fire damage reports. Multiple procedures completed annually. What kind of procedures? Employee health screenings mostly, and... She paused. Exploratory surgeries. Unspecified indication. All employees, all successful outcomes. Who are the patients? Another pause, longer this time. According to this, everyone who works in surgical services has had a procedure in OR 11 in the last 6 years, including you. You had yours in 2019. I've never had surgery. The records show you did. Exploratory procedure. OR 11, November 2019, surgeon unassigned. Post-op recovery noted as complete. I hung up. I checked my body that night, looking for scars, any evidence of a surgery I didn't remember. I found nothing. No marks, no healed incisions, no indication I'd ever been opened. But the pager in my locker now displays a different message. OR 11, post-op follow-up required. And sometimes late at night when the surgical wing is quiet, I can feel it. Not a scar, not pain, but a sense of something incomplete. Something that was started but never finished. A procedure that's still ongoing even though I'm awake, even though I'm working, even though I have no memory of being wheeled into OR 11 and draped and opened. The pager knows. The room knows. And eventually I'll have to report for closure, because in OR 11 no procedure ends until the room decides it's finished, and mine is still listed as active. Communication systems exist to summon help, to coordinate care, to keep surgical teams connected. But pager 11 doesn't transmit messages from the living staff. It transmits from room 11 itself, from procedures that never ended, from cases that remain perpetually open, from a surgical schedule that exists outside normal time. When you receive pages from a condemned room, you're not being contacted by accident. You're being reminded of an appointment you don't remember making, a procedure you don't remember consenting to, a surgery that's still in progress even though you're walking and working and breathing. The table is waiting, the lights are ready, and your chart still says procedure incomplete. The pager will keep buzzing until you return for closure. Story 12. Airway. Her lips moved, forming words despite full paralysis, despite sedation levels that should have erased consciousness. When I leaned closer, she whispered my childhood nickname. A name I hadn't heard in 20 years, a name no one in this hospital could possibly know. General anesthesia is a controlled obliteration of consciousness. The patient receives a combination of medications, hypnotics for unconsciousness, analgesics for pain control, and neuromuscular blocking agents for paralysis. When properly administered, the patient is completely unaware, unable to move, unable to feel, unable to form thoughts or memories. They don't speak. They don't react. They exist in a state of pharmaceutical suspension, maintained there by the anesthesiologist's careful calibration of drugs and doses. In 16 years as an OR nurse, I've never seen a properly anesthetized patient exhibit purposeful movement. Until Mrs. Covenant. She was a 72-year-old woman scheduled for a routine hip replacement in OR 5, osteoarthritis, mobility issues, no significant comorbidities. The preoperative assessment was unremarkable. She was pleasant, cooperative, slightly nervous, but reassured by our explanations of the procedure. Dr. Brennan was performing the surgery. Dr. Castellano was managing anesthesia. I was the circulating nurse. Standard team, standard procedure, everything by protocol. We wheeled Mrs. Covenant into the OR at 9:15 a.m. She smiled at us weakly as we transferred her to the surgical table, positioning her carefully, applying monitoring leads and blood pressure cuff. "You're doing great," I told her, my voice calm and practiced. "We're going to take excellent care of you." She nodded, her eyes already glazing slightly from the preoperative sedative she'd received in the prep area. Dr. Castellano began the anesthesia induction. Propofol through the IV line, followed by the neuromuscular blocker once she was unconscious. I watched her eyes close, watched her body relax into full sedation. "She's under," Dr. Castellano confirmed, checking her reflexes. "No response. Intubating now." He inserted the endotracheal tube smoothly, secured it, connected the ventilator. The machine began cycling, delivering oxygen-rich air into her lungs at controlled intervals. Mrs. Covenant's chest rose and fell mechanically, passively. She was completely still, completely silent, her face slack beneath the surgical draping. We began the procedure. 40 minutes into the surgery, Dr. Brennan was preparing the acetabular component, reaming the hip socket to receive the prosthetic cup. I was managing instruments, anticipating his requests, maintaining the sterile field. And then I saw Mrs. Covenant's lips move. Not a twitch, not a spasm, a deliberate movement, her mouth forming shapes, her lips pressing together and releasing, articulating something. I froze, staring at her face. "Dr. Castellano, is the patient moving?" He glanced up from his monitors. "Vitals are stable. Paralytic levels are therapeutic. She shouldn't be capable of voluntary movement. Check her face." He moved to her head and observed for a moment. Mrs. Covenant's lips moved again, subtle but unmistakable, forming syllables in silence. Dr. Castellano frowned and checked his medication logs. Paralytic was administered 22 minutes ago. She should be fully blocked. This shouldn't be possible. But she's moving. "I see it." He increased the paralytic dose slightly, then watched her face again. The lip movement stopped. "That should hold her," he said, though his voice carried uncertainty. I returned my attention to the surgical field, but my eyes kept drifting back to Mrs. Covenant's face. 5 minutes later, her lips moved again. This time, more deliberately, more insistently, and I could almost make out the word shapes, syllables, consonants, vowels forming in careful sequence. "She's doing it again," I said. Dr. Castellano administered another bolus of paralytic. "This is highly unusual. She should be completely immobile." But the movements continued, undeterred by the medication. Mrs. Covenant's mouth worked silently, speaking words that had no voice, articulating something that couldn't be articulated. I stepped closer to her head, leaning down, trying to read her lips. The shapes were clearer now, repeated, the same pattern over and over. "Wake up, wake up, wake up." I stepped back sharply. "What is she saying?" Dr. Castellano asked. I think she's saying wake up." He checked the monitors again. "She's deeply sedated. Brain activity is minimal. She's not conscious. This has to be involuntary muscle activity, some kind of residual motor function." But I knew what I'd seen. Those weren't random movements. They were words, purposeful, directed. And then Mrs. Covenant's lips formed something else, something longer, more specific. I leaned closer again, watching carefully. The lips moved slowly, deliberately, spelling out sounds. "Birdie." I went cold. Birdie. A nickname my grandmother had called me when I was a child. A name I hadn't heard since she died 20 years ago. A name that existed only in old family memories, never spoken in my professional life, never mentioned to colleagues or patients. No one in this hospital knew that name. "Dr. Castellano, she just said my childhood nickname." He looked at me, confused. "What?" "She mouthed Birdie. That's what my grandmother called me. There's no way she could know that. Harper, she's unconscious. She's not speaking to you. This is..." Mrs. Covenant's chest heaved suddenly, straining against the ventilator, her body trying to draw a breath independent of the machine. Alarm sounded. Dr. Castellano moved quickly, checking tube placement, adjusting ventilator settings. "She's fighting the vent. I'm increasing sedation." He pushed more propofol through the IV line. The alarms quieted. Mrs. Covenant's body relaxed back into passive compliance, but her lips kept moving, and now I could see condensation forming inside the ventilator tube. Not from the machine's breath, but from her mouth, as if she were exhaling against the airflow, fogging the clear plastic from the inside. The condensation formed patterns, letters, words written in breath vapor. "Wake up." I pointed at the tube. "Do you see that?" Dr. Castellano looked, his face paling. That's not possible. She's not exhaling. The ventilator is controlling all respiratory function." But the words remained, etched in moisture on the inside of the tube. "Wake up, Birdie." "How does she know my name?" I whispered. "Dr. Mailul." Brennan's voice cut through the tension. "Can we maintain anesthesia and finish this case, please?" Dr. Castellano nodded, his movements mechanical, his attention divided between the monitors and Mrs. Covenant's impossible words. The surgery continued. I performed my duties automatically, but I couldn't stop looking at her face, at her lips that kept moving, at the ventilator tube that kept fogging with messages I couldn't explain. "You're asleep, this isn't real, wake up." The words appeared and faded, each time slightly different, each time more insistent. The hip replacement was completed successfully. Dr. Brennan closed the incision and we prepared to transfer Mrs. Covenant to recovery. Dr. Castellano began lightening the anesthesia, reducing the propofol infusion, allowing her to emerge gradually from sedation. As consciousness returned, her lip movements stopped. The ventilator tube cleared. She took her first spontaneous breath, coughed lightly around the endotracheal tube, and blinked slowly as awareness returned. We extubated her carefully. She coughed again, cleared her throat, and looked around the recovery area with groggy confusion. "How do you feel?" I asked, my voice steady despite the tremor in my hands. "Tired," she murmured. "Did everything go okay?" "The surgery was successful. You're doing great." She smiled weakly and closed her eyes, drifting back into post-operative sleep. I stood beside her bed, watching her breathe naturally now, watching her face remain still and peaceful. And I wondered what she'd been trying to tell me. Mrs. Covenant recovered normally. She was transferred to the orthopedic ward, completed her physical therapy, and was discharged 5 days later in good condition. I checked on her once before she left, asking casually if she remembered anything unusual about the surgery. "Nothing," she said. "Just going to sleep and waking up afterward." "Why?" "No reason, just routine follow-up." She smiled. "You all took wonderful care of me. Thank you, Harper." I left her room and checked her medical records one more time. Preoperative intake forms, patient history, emergency contact information. And there, in the section listing previous hospitalizations, I found an entry from 20 years ago. Patient, Covenant, Margaret J. Admission date, August 2004. Reason: stroke, neurological complications, outcome: deceased Margaret, my grandmother's name. I pulled up the full record. Margaret Covenant had been admitted to this hospital's neurology ward in August 2004 after suffering a massive stroke. She died 3 days later. But that couldn't be the same person. My grandmother's last name was Mitchell, not Covenant, and she died in a different state, in a different hospital. I checked the patient photo from 2004. It was my grandmother's face. I went to medical records and requested personnel files from August 2004. I wanted to know who'd been working in this hospital 20 years ago, who might have known my grandmother, who could have told Mrs. Covenant about the nickname Birdie. The records showed that in August 2004 I'd been working here. My employment start date was listed as June 2004, 2 months before my grandmother died, but that was impossible. I didn't start working at this hospital until 2008. I was in nursing school in 2004. I'd been living in a different state. I pulled my own personnel file. The records were explicit. Collins, Harper E. Employment start date, June 7th, 2004. There were pay stubs, attendance records, performance reviews spanning 20 years. According to the hospital's records, I'd been working here continuously since 2004. Never left, never took a break, never had a gap in employment. But I have clear memories of nursing school from 2004 to 2007. I remember my graduation. I remember applying to this hospital in 2008. I remember my first day, don't I? I went back to OR 5 that night after my shift ended. The room was dark, clean, ready for the next day's cases. I stood where I'd stood during Mrs. Covenant's surgery, looking at the empty surgical table. And I saw, faintly visible on the mattress surface, a message written in condensation, as if someone had breathed on the material, fogging it with warm breath. "You're still asleep, Birdie." I reached out to touch it and my hand passed through the table's surface like it wasn't there. Like I wasn't there. I looked at my hands. They were solid, real, present. But when I held them up to the surgical light, I could see through them slightly. Not transparent, but translucent, as if I were slightly out of phase with the room. I left OR 5 and walked through the hospital corridors. Staff members passed me, nodding, acknowledging me, speaking to me normally. Everything seemed real, solid, continuous, but in every reflective surface, windows, monitors, polished doors, I could see the same message, faint but persistent. Wake up, I still work here. I still show up for shifts. I still scrub in for surgeries, maintain sterile fields, count instruments, complete my duties with professional precision. But sometimes during procedures I see patients' lips moving under anesthesia, speaking to me, calling me Birdie, telling me to wake up. And I wonder if Mrs. Covenant was my grandmother, if she was trying to reach me from wherever she is, trying to tell me that I never left August 2004, that I've been asleep for 20 years, dreaming this life, this career, this endless repetition of surgical cases in a hospital that exists somewhere between memory and consciousness. The ventilator tubes still fog with messages. The lips still move in paralyzed silence, and every time they spell out "wake up," I feel myself slipping, fading, becoming more translucent. One day I think I'll disappear completely. One day I'll wake up, and I don't know what year it will be, or if I'll still be Birdie, or if I'll be anyone at all. Anesthesia is supposed to silence the patient, to create a state where consciousness cannot emerge, where words cannot form, where awareness is chemically extinguished. But in OR 5, I learned that some patients don't speak from consciousness. They speak from somewhere else, somewhere deeper, where anesthesia cannot reach. They move their lips with messages that bypass sedation and paralysis, that fog ventilator tubes with warnings meant for the living, or for those who think they're living. When a patient calls you by a name you've forgotten, when they tell you to wake up, they're not emerging from anesthesia. You are. And the operating room around you begins to fade, revealing the truth that you've been the one under sedation all along. The procedure never ended. You just thought you'd woken up. Story 13. Post-op recovery. He was sitting upright, eyes open, smiling at nothing. But his monitors showed deep sedation, zero consciousness. When I blinked, the bed was empty. The heart rate monitor still beeped steadily, displaying my rhythm. Post-operative recovery is a phase of transition. Patients emerge from anesthesia gradually, moving through stages of consciousness, deep sedation, light sedation, drowsiness, full awareness. We monitor them carefully during this process, watching for complications, managing pain, ensuring their vital signs remain stable as the medications clear their systems. Most patients wake slowly. They murmur incoherently, move restlessly. Sometimes call out names or speak fragments of dreams. It's normal, expected, part of the emergence process. What isn't normal is waking completely while still fully sedated. I was assigned to the PACU, post-anesthesia care unit, for a night shift rotation. 6 beds, 3 patients currently recovering from evening surgeries. Standard monitoring equipment, standard protocols, standard layout. The first 2 patients were progressing normally. An elderly woman recovering from gallbladder removal, breathing steadily with oxygen supplementation. A middle-aged man post-hernia repair beginning to stir slightly. His sedation lightening on schedule. The third patient, bed 5, a man in his 40s named David Renner, had undergone an exploratory laparoscopy for suspected bowel obstruction. The procedure had been straightforward. No complications, and he'd been transferred to recovery 30 minutes ago. He was supposed to be deeply sedated. His monitors confirmed it. Propofol levels indicated continued heavy sedation. His consciousness score was minimal, and his respiratory drive was still primarily supported by supplemental oxygen. He shouldn't have been aware. He shouldn't have been able to move purposefully. He shouldn't have been able to open his eyes. But at 11:47 p.m., when I completed my rounds and approached bed 5 to check his vitals, David Renner was sitting upright, not struggling to sit up, not partially elevated. Sitting upright, fully vertical, his back straight, his head level, his eyes open and focused straight ahead, staring at the wall opposite his bed with a faint, placid smile. I stopped mid-step, my breath catching. "Mr. Renner?" No response. His eyes didn't move, his smile didn't change. He simply sat there, perfectly still, perfectly upright, breathing shallowly through his nose. I checked his monitors. Heart rate 68 steady, blood pressure 118/72 normal. Oxygen saturation 97%. Respiratory rate 10 supplemented, and his sedation score calculated automatically by the monitoring system based on medication levels and neurological indicators. Deep sedation, no awareness expected. "Mr. Renner, can you hear me?" Nothing. I moved closer, placing my hand gently on his shoulder. His skin was warm, his muscle tone normal. He didn't react to the touch, didn't blink, didn't shift his gaze. I waved my hand in front of his face, no tracking, no response. But he remained sitting upright, smiling at the wall as if held there by invisible support. I paged the attending anesthesiologist, Dr. Martinez, and explained the situation. She arrived within 3 minutes, her expression skeptical until she saw him herself. "That's not possible," she said quietly, checking his IV line, his medication pump, his sedation levels. "He should be unconscious. He received a full propofol infusion, and we haven't started lightening it yet. Should I lay him back down?" "Wait." She moved to stand directly in front of him, examining his eyes. "Pupils are reactive but sluggish. He's not tracking my movements. Neurologically, he appears deeply sedated, but his posture..." David Renner's smile widened slightly, just at the corners, a subtle shift that looked almost knowing. Dr. Martinez stepped back. "Lay him down gently. I'm going to adjust his sedation and run a neurological assessment." I placed my hands on his shoulders and eased him backward toward the pillow. He didn't resist, but he didn't help either. His body moved with passive compliance, like repositioning a mannequin. Once he was horizontal, his eyes remained open, staring at the ceiling now, smile still in place. Dr. Martinez administered a mild stimulant to counter some of the sedation, then performed reflex tests. No response. She checked for voluntary movement, for pupil constriction to command, for any sign of conscious awareness. Nothing. "He's deeply sedated," she confirmed. "No indication of awareness, but the sitting position..." She shook her head. "I've never seen that. I'll stay nearby. Page me if anything changes." She left. I remained at David Renner's bedside, watching him closely. His eyes stayed open, his smile stayed fixed, and for the next 20 minutes he lay there, motionless and silent. Then at 12:14 a.m. I blinked, a standard blink, a fraction of a second, and when my eyes opened, bed 5 was empty, not occupied. Empty. The sheets were smooth, the pillow undisturbed, the patient simply gone. I stared at the vacant bed, my pulse accelerating. I hadn't heard him move, hadn't heard the bed rails lower, hadn't heard footsteps, hadn't seen any motion in my peripheral vision. He'd simply vanished during a blink. I checked the floor around the bed, thinking maybe he'd fallen. Nothing. I checked the bathroom adjacent to the PSU. Empty. I looked down the hallway, searching for any sign of him. David Renner was gone, but his monitors were still active. The heart rate display still showed a steady rhythm, 68 beats per minute. The oxygen saturation still read 97%. The blood pressure cuff still attached to nothing somehow still registered 118/72. And the respiratory waveform still traced slow, shallow breaths across the screen. I checked the monitors more closely. The leads were still connected. I could see the electrode wires extending from the machine, terminating in nothing. They hung in the air where his chest should have been, still transmitting data, still displaying vital signs from a patient who wasn't there. I touched one of the electrode wires. It was taut, as if still adhered to skin, as if David Renner's chest were still present but invisible. I paged Dr. Martinez again, my voice unsteady. The patient in bed 5 is gone, but his monitors are still reading vitals. She returned immediately, and I showed her the empty bed, the active monitors, the leads extending to nothing. She stared in silence for a long moment, then reached out and disconnected the electrodes manually. The moment she pulled them free, the monitors flatlined, alarms sounding their continuous tones. She silenced the alarms and looked at me. Where did he go? I don't know. I blinked, and he was gone. That's not possible. Patients don't disappear. But we searched the entire PACU, the hallways, the adjacent rooms. We checked security footage. The cameras showed me standing at bed 5 watching the patient. Then a single frame of empty bed. Then me reacting to the absence. No movement, no transition, just present, then absent. 30 minutes later, I received a call from the main surgical ward. David Renner had been found in his pre-assigned recovery room, room 347, lying in bed, fully awake, complaining of mild discomfort but otherwise stable. How did he get there? I asked the floor nurse. He says you brought him up after recovery, that you discharged him from PACU around midnight. I didn't discharge him, he disappeared. Well, he's here now, and his charts show a normal post-op course. Discharged from PACU at 12:10 a.m. per your signature. I checked the records. There was my signature on the discharge form, my handwriting, my documentation. Patient recovered from anesthesia without complications. Vital signs stable. Transferred to room 347 at 12:10 a.m. But I hadn't written that. I hadn't transferred him. I went to room 347 and found David Renner sitting up in bed, eating crackers, looking entirely normal. Mr. Renner, do you remember being in the recovery room? He nodded. Yeah, you were taking care of me, then you walked me up here. Do you remember sitting up before you were fully awake? He frowned. I remember dreaming, maybe. I was sitting somewhere watching, but I don't think I was awake. Watching what? You, I think. And the other patients, and myself lying there. He smiled faintly. It was a weird dream. I returned to the PACU. The monitors for bed 5 were still disconnected, still silent, but when I passed by the bed, the heart rate monitor flickered on briefly. Not displaying David Renner's rhythm anymore, displaying mine. I checked my own pulse against the monitor. Perfect match, beat for beat. I powered off the monitor completely, unplugged it, and moved it to storage. But the next night, when I returned for another PACU shift, the monitor was back at bed 5, powered on, displaying a heart rate of 72. My resting heart rate, and in the empty bed someone had left an indentation in the pillow, head-shaped, as if someone had been lying there recently. I touched the pillow. It was warm. I still work in the PACU. I still monitor recovering patients, check vitals, document emergence from anesthesia. But I avoid bed 5 when I can, and when I can't, I'm careful not to blink while standing near it. Because sometimes late at night I see the shape of someone sitting upright in that bed. Not solid, not fully present. Just an outline, a suggestion, a smile directed at nothing. And the monitors activate on their own, displaying vitals that match mine exactly. I think David Renner is still there in some way. Still sitting up, still watching, still smiling. And I think he's not the only one. I think Bed 5 collects them. Patients who wake in the space between sedation and consciousness, who sit up while their monitors say they can't, who smile at something we can't see. And when they disappear, they don't really leave. They stay, watching, waiting, recording our rhythms. Recovery is supposed to be linear, a progression from unconscious to conscious, from patient to person, from monitored to mobile. But Bed 5 taught me that some patients wake into a different kind of recovery, one that exists between heartbeats and blinks, where monitors display vitals from bodies that aren't there, where sitting up doesn't require consciousness, where smiling means you've seen something the sedation was supposed to hide. The empty bed still registers life. The monitors still track rhythms, and when you stand too close, they start tracking yours, documenting a recovery you didn't know you needed, preparing you for a transfer you haven't consented to yet. Story 14, Closing Stitch. I pulled the suture through skin and something thicker than blood came with it. Dark, viscous, purposeful. When the incision was closed, the edges had formed words in perfect script. You finished your rotation. The patient's chart listed me as discharged. The closing stitch is a moment of completion. After hours of surgery, incision, dissection, repair, reconstruction, the final sutures seal the wound and mark the end of the procedure. It's methodical work, usually left to the surgeon or a senior resident, but occasionally delegated to experienced OR nurses who've mastered the technique. In 17 years of surgical nursing, I've performed closing sutures hundreds of times. Interrupted stitches, running sutures, subcuticular closures. The needle passes through skin edges, the thread pulls them together, the knots secure them in place. Simple, reliable, final. But the closing stitch I performed last Tuesday didn't seal a wound, it sealed me. The case was a routine partial colectomy in OR 7. The patient was a 68-year-old man with localized colon cancer, good prognosis, straightforward resection. Dr. Whitmore had completed the bowel anastomosis and we were in the final phase, closing the abdominal incision layer by layer. Dr. Whitmore finished the fascial closure and stepped back, stripping off his outer gloves. "Harper, take the skin closure, standard interrupted sutures." I nodded, moving into position at the surgical field. This was common practice. The surgeon handles the critical internal structures. The nurse completes the skin approximation. I'd done it countless times. I prepared the suture, 3 neuronylon on a curved cutting needle, standard for skin closure. I positioned the needle holder, aligned the incision edges, and began. The first stitch passed through the dermis smoothly. I pulled the thread through, tied the knot, cut the excess, and moved to the next position. Normal, routine, unremarkable. The second stitch felt different. The resistance was wrong. Not the usual texture of skin and subcutaneous tissue, but something denser, more fibrous. The needle pushed through with more effort, and when I pulled the thread to approximate the edges, it drew something with it. Not blood, not serous fluid, something thicker, dark, almost black, viscous like old oil. It clung to the suture thread, coating it, making the nylon glisten with an iridescent sheen. I paused, frowning. "Dr. Whitmore, are you seeing this?" He glanced over from the documentation station where he was completing operative notes. "Seeing what?" "The suture is pulling something unusual, dark fluid." He moved closer, examined the incision site. "I don't see anything abnormal. Looks like standard closure to me." I looked down at the suture thread. It was clean now, white nylon, no dark coating. But I'd seen it. I'd felt the resistance. Never mind. Must have been a shadow from the surgical light. I continued suturing. The third stitch was worse. The needle pierced skin and then seemed to pass through something else, Another layer, invisible but tangible, like puncturing through a membrane beneath the visible tissue. And when I pulled the thread through, the dark substance came again, more profuse this time, welling up from the incision edges and spreading across the suture path. But when I blinked, it was gone. Just normal tissue, normal blood, normal closure. I shook my head slightly, trying to clear whatever visual distortion was affecting me. Fatigue, maybe. I'd been working 12-hour shifts all week. I placed the 4th stitch, then the 5th, working my way down the incision line. Each suture felt increasingly wrong. The needle meeting strange resistance, the thread pulling through layers I couldn't see, the dark substance appearing and vanishing between blinks. And then, at the 8th stitch, I noticed the pattern. The sutures weren't just approximating skin edges, they were forming shapes. The placement, the angles, the spacing. They weren't following standard closure technique anymore. They were creating letters. I stopped, my hands frozen mid-motion, staring at the incision. The suture pattern, viewed from above, spelled something. The curves of the thread, the positions of the knots, the intervals between stitches. They formed words in looping cursive script. You finished. I stepped back from the table, my breath shallow. Dr. Whitmore. Almost done? He asked, not looking up from his documentation. The sutures are forming words. Now he looked up. What? The pattern, look at it. It spells something. He approached the table and examined my work. Harper, this is a standard closure. Interrupted sutures, even spacing, proper technique. I don't see any words. I looked at the incision again. The sutures were perfectly ordinary, scum, straight lines of approximation, medical and precise. No curves, no script, no message. But I'd seen it. I'd placed those stitches deliberately, following some impulse I didn't recognize, creating patterns I didn't intend. I think I need a break, I said quietly. You're almost finished. 3 more stitches. Just complete the closure and we'll get you some coffee. I nodded and returned to the incision. My hands moved automatically now, placing the remaining sutures without conscious thought, letting muscle memory complete the task. 9th stitch, 10th stitch, 11th stitch. And with each one I felt something pulling at me, sonund. Not physically, not from the surgical field, but from somewhere deeper. A sense of completion that extended beyond the procedure, beyond the patient, beyond the OR. I tied the final knot and cut the thread. The incision was closed, sealed, complete, and then the edges moved. Not opening, not bleeding, just shifting, the skin rippling slightly along the suture line, the stitches adjusting themselves, tightening, rearranging. The pattern emerged clearly now, undeniable, visible even to my fatigued eyes. You finished your rotation. I stared at the words spelled out in black nylon against pink skin, perfect and impossible. Dr. Whitmore, look at this, please. He leaned over the patient, his eyes scanning the closure. For a long moment, he said nothing. Then, Harper, I've never seen... You see it now? I see something. The suture pattern is irregular, but it doesn't spell anything. It just looks wrong. He reached for a hemostat, as if to adjust the stitches, but the moment his instrument touched the suture line, the words rearranged themselves into standard closure pattern. Perfect, medical, normal. He stepped back. False alarm, looks fine now. Good work. Let's close up and transfer the patient. But I could still see the words beneath the surface, like a watermark visible only at certain angles, certain light. You finished your rotation after the case. I went to the staff locker room and sat on the bench staring at my hands. They looked normal. No tremor. No sign of the strange resistance I'd felt during the closure. But when I turned my palms up and examined the skin closely, I saw something that made my stomach drop. Faint lines, thin, precise, running across my palms in patterns that looked almost like Sutures, not scars, not cuts. Just lines as if someone had traced suture patterns onto my skin with an invisible needle. And when I looked closely at the pattern, I could read it. Discharged. I scrubbed my hands at the sink, washing vigorously, but the lines remained. Not raised, not discolored. Just present, like they'd been there forever, and I was only now seeing them. I checked the surgical schedule on my phone. I was scheduled for OR 7 tomorrow. Another colectomy, another closure. I canceled the assignment and requested a personal day. That night, I received an email from hospital administration. Subject: rotation completion confirmation. Dear Harper Collins, this message confirms the completion of your surgical services rotation as of today's date. Your assignment in operating room services has been fulfilled per the terms of your initial employment agreement dated June 7, 2004. Please report to Human Resources to finalize your discharge paperwork and receive your rotation completion certificate. Congratulations on completing your service. I read the email 3 times, my hands shaking. I'd never signed up for a rotation. I'd been a permanent employee for 17 years. No rotation, no term limit, no completion date. I called Human Resources. The office was closed, automated message only. I called my supervisor. No answer. I called Dr. Whitmore. Voicemail. I drove to the hospital even though my shift didn't start until morning and went directly to Human Resources. The office was dark, but the door was unlocked. Inside, on the reception desk, was a folder with my name on it. I opened it. Inside were discharge documents dated today, signed by administrators I'd never met, and a certificate printed on heavy cardstock. Certificate of Rotation Completion, Harper Elise Collins, Operating Room Nurse Rotation Period, June 7, 2004, counter today's date. Status: discharged 20 years to the day. I checked the date I'd started working here. June 7, 2004, exactly 20 years ago. But I didn't remember it being called a rotation. I remembered applying for a permanent position, signing an employment contract, starting a career. When had it become a rotation? I returned to OR 7, the room where I'd performed the closing stitch. The lights were off, the space empty and clean. I stood where I'd stood during the procedure, looking at the surgical table. And on the table, illuminated by emergency lighting, was a patient chart. I approached slowly and opened it. Patient name: Collins Harper E. Procedure, rotation completion status, discharge date. Today, notes: final closure completed, sutures intact, recovery pending. Under surgeon, the field was blank. Under anesthesia, it read, self-administered. Under complications, it said, patient unaware of procedure until closing stitch. I closed the chart and looked at my hands again. The suture patterns on my palms were more pronounced now, darker, more defined, and I understood. I hadn't been closing the patient's incision. I'd been closing mine, sealing the rotation, completing the procedure, finishing the term that had been running since 2004. I'd been the patient all along. I still go to the hospital, I still show up at the surgical wing, but when I try to enter the OR, my badge doesn't work. The doors don't recognize me. Security logs show my employment status as discharged. I can see through the observation windows. I can watch the surgeries, but I can't enter. I'm outside the sterile field now, permanently. And sometimes, late at night, I see someone in OR 7 performing closing sutures. Someone who looks like me, who moves like me, who places stitches with my exact technique. She doesn't know yet. She doesn't see the pattern forming. She doesn't realize that each stitch is counting down her rotation, marking time until the final closure. Until the incision spells her name and the chart lists her as discharged. The closing stitch doesn't end the procedure. It documents the completion of service. And once your rotation is finished, you can't re-enter. You can only watch through glass as someone else takes your place. picks up the needle and begins closing their own incision without realizing it. Stitch by stitch, year by year, until the words appear. And they're discharged too. Every surgical rotation has a term limit, even when you don't remember signing up for one. The closing stitch isn't just sealing the patient's incision. It's marking the completion of something older, something agreed to in documents you don't recall signing, in contracts that existed before you arrived. The sutures spell it out in patterns you can only see at the end, when the final knot is tied and you realize you weren't closing the wound. You were closing yourself out. The discharge papers are already printed, the replacement is already scrubbing in, and when you try to return to the OR, you'll find you've been marked as complete, sealed by your own final stitch, unable to re-enter the sterile field you once called home. The rotation is finished, the service is rendered, and the next nurse picks up the needle, never knowing that each closing stitch brings them one step closer to the same realization. This was never permanent. It was always going to end with you on the outside, watching yourself being replaced, one suture at a time,